Hi, Demetrius. I think we're ready to start.
Okay. So we can start. First of all, good morning to everybody. I would like to welcome you all on this conference. It's the fourth annual Bronchiectasis Patient Conference. Sorry for my English. My mother language is Greek. I also speak very good Spanish, but the English is not the strong part of me. But this is the reason why we encourage patients to get connected because the language has not been a barrier to our common vision. So this conference is one of the highlights of our year and brings together an amazing community from across the world, from different countries, and people living with bronchiectasis who are a lot of time are isolated and they are thirsty to learn and to share experience together along with the healthcare professional that work in the field. So we are very proud for our collaboration with Embark and the respiratory healthcare professionals who have been working this partnership for more than 10 years. And we hope together with the wonderful group of patient advisory group, the patient members from different countries, to drive us to improve the treatment, to improve the care, and at the end of the day, we want to improve the lives of people with bronchiectasis. I hope you have a comfortable chair now, and we will have an informative day to learn more things, to share experiences. And as I already said, at the end of the day, we want our patients to be empowered, to feel being a community and with the protection and the care of healthcare experts. So, as you can see possibly in your screen, in this event, we have a translation app. It's Wordly, the name is Wordly, and this provides automatic translation in over of 50 languages. And this is that I told you in the start that we want to communicate and the language to not to be another barrier among our communities. So we have posted the link in the chat box. You can see there the QR code. And when you access the app, you select the language that you want to click here and start, and then you can click the attend. So then the Wordly will open a screen, and you can have it both screens during the webinar. So you can read also the transcript on your device or use a headset to listen to the audio. Do remember to
at the bottom of this the screen.
Yes, correct. And finally, remember that automatic translation is never perfect. A lot of times, it's some different difficult words, especially in healthcare rules. But we hope this tool help us to communicate better. If you have any problem accessing the app, you can send directly now to info europeanlang.org, and one of the member of our team that is in backstage will instead help you. So this was about the welcome introduction. In order to bit more warm up, I will have a final task. We will make a poll question, and you are invited now that you will see a pop-up that appear in the screen to answer a simple and easy question. And the question is, which country are you joining us from today? So you can do it now. I do it by myself also. And let's see how many from each country we are. UK, Oh, Jordan, UK, Netherlands. We have a variety of countries. Some are more quickly than others. Italy, okay, Australia, very nice. So it's very nice that we have people from all over the world. And the final mission, the mission from today is to get more information, to empower our community, to get connected. And now I think it's the time to pass to the other co-host of the conference, Elisa, that is a Greek friend also, and Mikhail, to introduce themselves and to give us what are the updates of bronchiectasis today. So enjoy the conference. Bye from me, and thank you very much for joining.
Thank you, Dimitris. Hello. Thank you, Dimitris. Hello, everyone. My name is Elisa Kombatsiari. I have been a member of the PAG since 2021, and in particular, I decided to join PAG immediately after its first bronchiectasis patient conference. This had a huge impact in my life because it happened at a time when I really needed information about bronchiectasis. The conference was my first introduction to things like airway clearance, but also it made me realize that there were others with the same condition, people with whom our symptoms were sometimes very similar and sometimes very different. But suddenly, after all these years, there were others living with bronchiectasis. During these 3 years, I have not only learned a lot about bronchiectasis, but I have also participated actively in the activities of the group. I'm very proud of what our group, together with the experts from EMBARC, have achieved. And this is why I'm very happy to be here today, but also because our conference seems to have become an annual event. So whether you have been here before or not, I hope our conference will answer many of your questions, and also that it gives you ideas and tips on how to manage your bronchiectasis in your own way. And I will now hand over to Mikhail, my co-host, to introduce yourself.
Thank you, Elisa, and good morning, everyone. My name is Professor Michal Steinberg. I'm a pulmonologist working in Haifa, Israel, and I specialize in bronchiectasis and adult CF. I'm a member of EMBARC, the collaboration of clinicians and researchers dedicated to promote bronchiectasis research and care. And for the past 5 years, I've been involved with ELF, with the Patient Advisory Group, and we've been doing many exciting projects together to help promote the knowledge of bronchiectasis among people with bronchiectasis. And I'm especially excited to welcome all of you to the 4th annual Patient Bronchiectasis Conference. So, Eliza, please go on.
Yes, I have now a few housekeeping things to make you aware. So this is a webinar. We can't see or hear you. You can only see the speakers and the chairs and hosts. But please do get involved, participate in the chat and through the Q&A. The Q&A, please write your questions for the speakers there. We will try to answer as many as we can. For those that we cannot answer because we won't have time to do so, we will try to answer it later on and put it in the website of ELF. There are expert clinicians answering your questions today, but please keep in mind that we cannot answer questions about anyone's personal circumstances or case. To participate in the polls, we had already one, but there will be several polls. And if you use social media, then tweet using the hashtag bronchiectasis2024 and tag ELF, EMBARC, and the ERS. The conference is being recorded, and talks will be made available on the ELF website and ERS respiratory channel after the event. So hand back to you, Mikhail.
So today's conference is organized as a collaboration between the European Lung Foundation, ELF, and EMBARC. And you can see, you can find out more about these organizations at the link shown here. And these are just some of the members of the bronchiectasis patient advisory group. They're all volunteering to help. And special thanks go to Barbara, Fran, and Elisa, who sat on our conference planning working group and helped to plan this event today. Our audience today is made of people with bronchiectasis and family members, but we also welcome healthcare professionals, medical students, patient organization representatives, and members of the public who've joined us. And we're proud to have more than 1,700 registrations from 90 countries. I also want to take this opportunity to introduce Rose Matheson, who's a visual monitor today. Rose is a qualified paramedic who also provides visual minutes for events utilizing her scientific background and creative flair. As a lecturer in higher education, she's realized the impact of providing visual representations of complex scientific topics in a fun and novel way, which has helped paramedic learners and introducing these concepts to a wider audience. Rose is going to be creating summaries of all the talks today using words and images, and these will be useful to you and anyone wanting to access the conference content after today. Welcome, Rose. And we'll be getting back to Rose after the break to see how she's getting on with her drawings. Remember to put your questions in the Q&A box. And remember, we can't answer any questions about anyone's personal condition. If you like any question that you want to be answered, like it and use the thumbs up button to highlight, and it will flag it up to the conference chairs, and also avoid duplication of questions. Elisa?
Now, just a bit of the outline of the day. We have a mix of patient speakers and healthcare professional experts. You can access the program by clicking on the resources icon along the bottom of the Zoom screen. It's also available on the ELF website, and we'll put a link into the chat. There are 4 main sessions today. Each one has 2 co-hosts, a patient and a clinician. They will introduce the speakers and coordinate questions at the end of each session. There is time allocated for questions after each session. Session 1 is an overview of bronchiectasis. Session 2 focuses on the future and the new research that has been going on. Then we have a break, and then session 3 will deal with the issues arising from living with bronchiectasis alongside other conditions. Then again, we have a smaller break, and finally, session 4 is dedicated to shared decision-making and what works in bronchiectasis. So now we will move on into our first session, but before I introduce our first speaker, let's just do another poll. To answer the question, click on the link on the pop-up that will appear on the screen, or you can click on the link that is in the chat, or scan the QR code. I think they will appear. A QR code must appear in your screen. Well, the question is, where do you find trusted information about your condition? You can type your answer, but you must keep your answer short, just 1 or 2 words. Let's see what comes up. Online, Lung UK, doctors, ELF website, medical professional, American Lung site, okay, nurse, consultants. Let's give it a little bit more of time. That's great. Thank you for participating on that. And now it gives me great pleasure to introduce our first talk, which gives a basic overview of bronchiectasis by Professor Lucy Morgan from Australia. Lucy is a lung specialist working in Sydney. She was the foundation chair of the Australasian Bronchiectasis Consortium and the Australian Bronchiectasis Registry, and is now chair of Lung Foundation Australia. Lucy?
Thank you, Eliza. Thank you so much for having me. It's lovely to be with you. Of course, it's the evening here in Australia, and it's only 7 o'clock, not too late. But while you're all having your morning coffee, I'm ready for a glass of wine. So I'm hoping you can see my slides. So I'd like to introduce my session by saying this is a talk I prepared for those members of our family, of our new bronchiectasis family who are just joining us. My presentation is for a first-timer, for somebody who's not been part of this group before. So I make no apologies for that. There will be some rather graphic food analogies, and if that upsets anybody, if, for example, you think you might not be able to eat guacamole ever again, then I'll ask you to just turn away when I make my food analogies. So this is an introductory slide that shows my beautiful city, Sydney. So today I'm actually presenting this presentation from Brisbane, or from the Gold Coast, which is in Queensland, about 1,000 kilometres away from my hometown of Sydney, because this is our big national meeting this week, and I've just given a presentation about bronchiectasis to my colleagues here in the Gold Coast. But I work at 2 busy public teaching hospitals in Sydney, and I am, as Eliza mentioned, I am chair of Lung Foundation Australia. So I'm hoping that these slides will all work. So I'd like you to suspend belief for a moment and think about your lungs as being a bit like a fresh piece, 2 fresh pieces of fresh cake or fresh bread. Imagine that healthy, normal lungs are like 2 pieces of fresh bread or fresh cake, wrapped perhaps in 2 layers of cling wrap. I won't use a brand name here. And then both of those beautiful pieces of fresh lung sitting in the cake tin of our chest wall. So that's what normal lungs look like. The air gets in and out of those lungs via a set of tubular structures that we call the bronchi. So that's the medical name for the airways. But they're like straws taking air in and out of the spongy lung. Now, bronchiectasis is the construct where that fresh spongy lung is changed from soft and squishy, small air spaces with nice tapering airways to an organ that looks a little bit more like a crumpet. So my English friends will know exactly what a crumpet looks like. It's a bit stiffer than fresh cake. It's a bit leathery, and there are holes in it. And you all know what happens if you put a bit of honey and butter onto a warm crumpet. It all soaks into the holes of the the crumpet. And that's a bit like what happens when we've got dilated airways that become a fabulous nidus for mucus, the butter and honey, to build up. Now, my dear Greek colleagues will know and be able to tell us all that bronchiectasis comes from the Greek. Bronchiectasis describes a process. It's a big, long word, but it describes a process where the airways, the bronchi, are dilated or ectatic. So bronchiectasis describes a process where, for one reason or another, these beautifully tapering airways have become dilated in in various, not necessarily all of them, but at least some of them. And these dilated airways can become an opportunity for mucus to build up, to impair their ability for the mucus to be cleared from the airways, and for this whole conundrum to produce a syndrome of symptoms for patients. So what patients with bronchiectasis experience is a syndrome of cough, of sputum production, of recurrent chest infections that over time is associated with fatigue, so feeling really tired, with the process of sometimes coughing up a bit of blood, with often coughing up phlegm or mucus of varying different colours and thicknesses and tastes, and of often feeling quite breathless. So there are a series of symptoms that are associated with the syndrome, associated with bronchiectasis. So how does it happen? So doctors talk about a concept called pathogenesis. That means, how did it happen? How is it that these airways that were so beautifully designed to be tapered like a lovely slender carrot or a root or something like that should become so dilated? How is it that a process where spongy lung that should look like fresh cake can become a bit like a crumpet? So this is the CT scan of a patient with quite diffuse or bronchiectasis in lots of parts of their lung. So how does it happen? Well, we think that at some point there's been some interruption of or impairment of one of the processes that usually keeps our lungs clean. And often by the time there's radiological change, so there's a change on a CT scan, this is something that's been going on for a very long time. It's very unusual for this sort of radiological or CT change to happen over months or weeks. This is the sort of change that's happened over years. And so anything that interrupts the things that keep our lungs healthy and clean can lead to this bronchiectatic process. So something that interrupts the lining cells of our airways, that interrupts or changes the way that mucus is secreted. Mucus, of course, is that snotty stuff that we cough out. Mucus can become thicker than usual. It can be secreted in larger amounts than usual. And anything that interrupts our lungs' way of keeping itself healthy and clean, so this is the mucociliary escalator, or part of the body that is designed to help sweep the lungs clean of muck. Anything that goes wrong with that process can lead to bronchiectasis. Anything that leads to a chronic, meaning a long-standing inflammatory process, whether that be associated with an inflammatory condition, something like arthritis, rheumatoid arthritis, or something like that, that can lead to an abnormality that can lead to bronchiectasis. Anything that precipitates or leads to a chronic, meaning persisting infection, can lead to the sort of changes that we talk about, the crumpety lung syndrome. And anything that leads to the destruction of the airways, so anything that leads to actual cell damage can lead to this crumpety lung syndrome or bronchiectasis. So really, you don't have to know too much about the various conditions or diseases themselves. But if you think about it from first principles, anything that blocks the pipes, so the airways, especially if there's muck or secretions that are very sticky that blocks the pipes, or anything that narrows the pipes, that can lead to this bronchiectasis. Anything that leads to tissue damage. So I've got this I think you would say was kitchen porn, food porn, but this is to remind me that things that lead to radiation damage to the lung, and the most common condition I have to say in my practice is women who've had radiotherapy for breast cancer. This is where the radiation therapy is designed to, get rid of the cancer cells that are in the breast. But if the lung is right behind that, then the healing rays can also be associated with damage to the spongy lung that's just behind it. And these are a set of pictures taken on my kitchen bench recently. So this is to show us that, and this of course is mustard, but is to be illustrative of the fact that if there's pus or infection in the lung for any significant amount of time, this can also be associated with tissue damage in the lung that can lead to this bronchiectasis. So I'm sorry about the food analogies, and it's only going to get worse. You should be grateful that it's not dinner time for most of you. Okay, so now let me continue that food analogy to talk about the construct of what I call mucky crumpet. All right, if we think about the damaged lung being more like a crumpet than a healthy sponge cake, then if you get a lot of infected mucus in that lung, in those airways, so if the sputum becomes thicker than normal, if it's got bacteria growing in it, then the sputum becomes much muckier. It's full of cells. It can taste bad. It is thicker and harder to cough out or to expectorate. And infected muck, being smelly and thick and discoloured, tastes very bad and contributes a lot to the symptom burden of patients who are trying to cough it out, who are experiencing bronchiectasis. So this is what the lung looks like when there's bronchiectasis with a lot of sputum or a lot of secretions in a crumpet. Some patients with bronchiectasis also cough up blood, and this is called hemoptysis, another Greek word. So heme tells us that it's blood. Optysis is the word that tells us that the secretions are being coughed up. So hemoptysis is the coughing up of blood. For many patients with bronchiectasis, this might be a little bit of streaky hemoptysis, which is a bit like the concept of jam that's been mixed with your custard. So discoloured sputum that's thick and perhaps custardy looking, a bit yellow, a bit green, but with some streaks of red in it. That's what we call streaky hemoptysis. If you wanted to have a more savoury analogy, rather than jam mixed with custard, you might think it's Tabasco sauce with your guacamole. Now, this kind of streaky hemoptysis, so not too much blood, it's unsettling, but perhaps not as scary as coughing up a cup of bright blood. This is a very common phenomenon when people with bronchiectasis have an infection. So a worsening of their cough than usual, often after a viral infection, but an infective flare-up of baseline symptoms is often associated with a bit of streaky hemoptysis. And this is my kitchen bench, and this crumpet is to remind us that this is the mucus with the infected material, and telling us that the airways themselves are quite inflamed and therefore a bit leaky or gooey. This is in stark contrast, however, to the concept of frank hemoptysis, which is not custard with streaks of jam, but in fact globules or larger volumes of quite bright red blood. And this is more like producing a mouthful of strawberry jam. This is a much more frightening experience for patients. There's nothing, it's a pretty terrifying thing to cough up bright blood. And if there's a large amount of bright blood, persistent coughing of bright blood, it might be a handful, it might be a cupful, it might be a few spoonfuls, but if it continues, that is what I tell my patients is a relative medical emergency. Hopefully, many of you will have never had this experience, but I would bet that there are some of you who have coughed up globs of strawberry jam. And this is different to an infective exacerbation. This implies to me, or it makes me worry, that in fact, as part of the process, some of the little tiny blood vessels that are very close to those airways have actually been eroded or damaged by chronic infection. And the trouble is those blood vessels, although they're very tiny, are under very high pressure. So they've got the same sort of pressure as our blood pressure. It's under high blood pressure. And so coughing up bright strawberry jam can actually be in gushes or spurts because it's systemic pressure. It's like turning on the hose with a spray nozzle on. This is a medical emergency and requires a very different bronchiectasis action plan to the streaky hemoptysis that we talked about earlier. So let's talk about another medical term in bronchiectasis care. That's the concept of exacerbation. I don't know why, but us doctors feel the need to have at least 4 syllables in all the big words that are really important in bronchiectasis care. But if exacerbation is not a familiar term, think about it as a flare-up of baseline symptoms. So baseline symptoms are your day-to-day symptom burden. How much cough do you have on a normal day? How much muck or phlegm or sputum do you produce on an ordinary day? How much of a normal night do you spend waking with cough? And how much time of your normal activities of daily living is spent impaired in terms of exercise tolerance? That's your baseline symptoms. So an exacerbation or a flare-up is a time when all of that is worse than usual. Some people call them a lung attack. And in fact, if we think about the analogy between heart attacks and lung attacks, a flare-up of bronchiectasis has the same sort of signal that things are going wrong that an episode of chest pain has for someone who has angina. They're not to be ignored. They're very important signals for us all that things are not in their normal state. So a chest infection is is another word for what we're describing. But remember, it's when your cough is worse than usual, when your breathlessness is worse than usual, and when sputum, the mucky stuff, is worse than usual. It might be smellier, it will be thicker, and it might be a different colour. So looking greener, greyer, thicker, yellower, and sometimes it might have blood in it. I think it's worth exploring that for yourself in your own mind. What are my baseline symptoms like? And how do I know that I'm worse than usual? Because that distinction will be different for absolutely every individual that's online today. So exacerbations in themselves can be quite sweet and not particularly scary. But exacerbations are bad for patients with bronchiectasis. Every single one of them brings an increased risk of further bad things happening. And even though, like these kittens, each one of them is not that scary looking, exacerbations are bad, and lots of exacerbations are lots more bad, so are very bad. Every time a patient with bronchiectasis has a flare-up or an exacerbation, it does increase the risk of future flare-ups, future exacerbations. And every time a patient has a severe exacerbation, the risk of something really bad happening increases. So exacerbations are bad, lots of exacerbations are bad, and severe exacerbations are very bad and really worth avoiding if we possibly can. I don't want to scare people, but I think it is important to remember this kitten and panther analogy. A severe exacerbation, you'll know it if you have it. You feel very sick. You are so sick that you definitely need medical care, And severe exacerbations are, often need care in hospital. That might be for antibiotics intravenously, it might be for oxygen, or it might be for fluid support or respiratory support if you can't breathe properly or keep your blood pressure up without extra support. Every admission to hospital with bronchiectasis flare-up increases the risk of further exacerbations, and it increases the risk of other bad stuff happening, whether that's medication errors, falling out of bed, getting a secondary infection, or even just missing work, missing your family, and missing your activities of normal activities of daily living. Every time you have an exacerbation that's bad enough to lead you to be in hospital, there's a decrease in your energy levels. There is loss of muscle bulk, and there is, as I said, an increased risk that other bad things would happen. So if we can avoid the panthers, we absolutely should. If we can avoid lots of kittens in the basket, we absolutely should. And if we can avoid any kittens or any flare-ups, then that would be even better. So we can't at this point turn crumpety lung back into fresh sponge tape. However, there is a good and strong evidence base for things that we can do to keep our crumpet dry, okay? To empty the crumpet and to minimize the muckiness of the crumpet. What can we do to minimize flare-ups? Well, we can vaccinate against vaccine-preventable diseases. We're all really familiar with the concept of minimizing our COVID risk, but remember that influenza, ordinary rhinovirus, are also potent causes of exacerbations. We don't have a vaccine for ordinary head colds, but we do now have access to vaccines for RSV, that's respiratory syncytial virus. We have great vaccines for influenza, and we have great vaccines for COVID, for SARS-CoV-2 or COVID illness. Exercise and airway clearance is something you're going to hear a lot about today. And there's absolutely no doubt that keeping the rest of our muscles strong and keeping us active and as busy as possible and as fit as possible, as well as augmenting or facilitating an increase in airway clearance, turning our mucky crumpet into a dry crumpet. This is something that not only reduces day-to-day symptom burden, but improves sleep quality, improves mood, and reduces exacerbation frequency. Sometimes you and your doctor might decide to consider maintenance antibiotics. So this is not short courses of antibiotics to treat a flare-up, but in fact, antibiotics for a longer period of time, maybe 3 months at a time. They might be tablet antibiotics, or they might be inhaled antibiotics, aimed at suppressing and drying up as much of that guacamole and that muckiness as possible to, again, reduce exacerbations. And treating other health problems as best we can is also a very important part of minimizing flare-ups or exacerbations, ways of keeping our crumpet dry. So managing asthma as best we can to minimize flare-ups and minimize day-to-day symptoms. Minimizing reflux symptoms, so that's heartburn and indigestion, because soiling of the lung or the crumpet or with contents from the stomach is a potent way to stir up inflammation. So minimizing asthma, minimizing reflux symptoms, and treating sinusitis as best in an evidence-based way are all very important. This is almost to the end of my presentation, and this is a cartoon that comes from a very old English rhyme. So those of us who are on the line from the UK might know the riddle, this riddle. As I was going to St. Ives, I met a man with many wives, 7 wives. Each wife had 7 sacks. Each sack had 7 cats, kittens, cats, sacks, wives. how many were going to St. Ives? Now, somebody anonymously wrote a bronchiectasis exacerbation riddle to go along with this. And this one was slightly different. It's still the man, as I was going to St. Ives, I met a man with many wives. But the riddle of exacerbations is a bit different. They creep in the night, they sleep under the, I can't remember what I said. What the synonymous, they sleep under the sill. They bring cough and fatigue. They make us all ill. Even a little one causes a fret. The more there are, the worse things get. The worse things get, the steeper the slide. When the vortex of inflammation is spinning, run and hide. This is a silly riddle, but just to remember that really exacerbations is the one baddie in the system that we can potentially minimize, and that strategies for all of us in our relationships with our doctors, with our health, with all our healthcare professionals and providers, and in fact, as a community of patients and clinicians interested in bronchiectasis, that this exacerbation frequency is the one thing that we can really target to minimize. I'm sorry, my food analogies were really quite disgusting. At least you've had your breakfast. I'd be really happy to take questions now, and I'm going to stay on for a bit longer for the rest of this session. Thanks very much for having me.
So thank you very much, Lucy. And I know the food analogies. I know that I've looked at the chat. Some really like them. I like them, and some don't. So it's different people like different things. For me, I need an avocado sandwich now. So thank you very much, Lucy. And we have some really interesting questions in the Q&A. We've answered some of these, and we'll try to answer others in the Q&A session coming up. And now I would like to introduce my co-host, Elisa Compastiari. And as Elisa was introducing herself, she's a lawyer working in Greece, and she's also a very active member of the bronchiectasis patient advisory group since 2021. And Elisa will talk about the patient resources. So please go ahead.
Thank you, Mikhail. Let me just share my screen. 8 minutes.
Hi, Eliza. Can you?
Sorry, just a minute. I think you know what went wrong. Yes.
We can see your screen now. You just need to go into presentation mode.
Yeah. Is that okay?
Yes, perfect.
Great, thank you. Okay, so I'm going to talk about bronchiectasis patient resources, and basically resources that are available for patients that have been produced by the ELF Patient Advisory Group together with EMBARC. And first, I want to talk a little bit about the PAG, just to show you how many we are and from which countries at the moment. The group started in 2017 with much fewer members, but it's a dynamic group, so people are coming and going. We have people that have been with us since 2017. We're very grateful for that. But it's a group that pretty much everyone gives as much time available as they have. And we do represent the group in several other projects and committees. Here you can see some of them, and you can see that we do have a very strong collaboration with EMPARC. We're very grateful for that. And okay, so for a start, for people with bronchiectasis to find information about bronchiectasis, we have gathered everything on one website. So this is the link. I think this must be here now in the chat. You can click on that and go to the ELF website. You can find information about bronchiectasis in different languages, and you can find there information on the basics of bronchiectasis, but also on more specific subjects like drugs that are under development, and also how to travel bronchiectasis. It is updated constantly. Actually, it was updated yesterday, and it's always in collaboration with experts. Now, if you scroll down in that link, you will find a self-care guide, and you might find it either by scrolling down or going to patient resources. So it's in several languages. It was launched in the 1st of July of 2023. So it was our own celebration of World Bronchiectasis Day. And its main characteristic is that it's written from people with bronchiectasis to people with bronchiectasis. Again, it is revised by experts. So it's again a collaboration with EMPARC, but it's in plain language things that we found helpful. So we describe bronchiectasis and how to expect in simple language, but also give tips and ideas that, okay, some of them might not be for everyone. We know everyone is different, but well, we have found that airway clearance, for example, exercise and diet are some things that can help us to cope with symptoms of bronchiectasis, but also it has to do with anxiety and bronchiectasis and social issues and bronchiectasis. And I have to say, it was first launched only in English and Italian, and we are very happy that it has been available in other languages, because the aim of this guide is not just to be a resource that someone will find online, but we wanted to go further to people that might not know it, that people might be of older age, and for example, they wouldn't speak English. And so we do want this to be in hospitals, in doctors' offices, and to be circulated to everyone with bronchiectasis. So if your language is not here, let us know, and we will try to do our best and include it in further translations. Another resource that I wanted to speak about is the bronchiectasis patient checklist. This was launched a longer time ago. It was one of the first projects of the PAG. It's available in some languages, and it's what to expect from your specialist, and also what to ask from your specialist. Now, not all of us had the great experience when they were first diagnosed with bronchiectasis. So it's just a list, a checklist that you should go on step by step and make sure you pretty much know the answers to all of it, and you have discussed it with your experts. It is based on the European Bronchiectasis Guidelines of 2017, which are now under revision. And we will have also new guidelines perhaps next year. But you can also refer to our previous patient conference. So just like this one all previous patient conferences for bronchiectasis were recorded. We're happy that we got nice feedback for them. You can find them in the website of this event, and there you can find things like airway clearance techniques, antibiotics, diets and nutrition, exacerbation, pseudomonas, mental health, pregnancy and fertility, and bronchiectasis through the ages, so from childhood to older age, also the participation in clinical trials. Now, we had been very on not having no medical language on that, so we try to keep it practical and to keep it simple, and it's always a collaboration with experts and patients. So these were what we have achieved already, and these are some of our future plans. So a sputum testing guide was something that we were interested in developing in the future. So questions like when to do this test and also how to perform it better in order to give a better sample, as well as how to interpret the results has been one of our interests. Also a guide on nebulizers. Many of us do take inhaled antibiotics, but also other, we use nebulizer. So this is also something important for us. But also we want to maybe do surveys, participate on surveys or develop surveys in subjects with few or no studies. And some of these are, well, the holistic care. Many of us have found that we do go from one doctor to another and from one expert to another, and we would really like them to collaborate together. So we really need a multidisciplinary approach. This is important for us, and well, COVID has showed that this is something that is achievable. It was a good, we had good practices on that from long COVID treatment. So we were thinking of having it also for bronchiectasis and also focusing on gut symptoms. This is quite common on people with bronchiectasis to have problems on their guts and bowels. So that's another subject we would like more surveys to take place. And also finally, women and men and bronchiectasis. So difference that may appear, but also more specific subjects like, for example, menopause and bronchiectasis, or pregnancy and bronchiectasis, things like that are some of our discussions for the future plans, but we do want to hear from you. So what would you like information on? Again, we have a poll. Write your answers using preferably one keyword, and you have these three options. Let's see what you all are thinking. This will give us feedback, and it will help us, focus on what other people like. So, mental health, menopause, research on cure. There are quite some answers. Let's see. That's great. I think menopause has gathered a lot of answers, research on cure, further treatments, future treatments. That's something we definitely are looking forward to, and we do deal with this. This is why we always include it in the conferences, this next session. So I'll just give it a few seconds more for everyone
Lisa,
to...
I can see some people writing down in the chat.
Yeah.
So it's really nice to get that. Maybe we'll get after the conference, we'll get all the answers from the chat, although it's not in the Mentimeter.
Exactly. And I think that we will send an email asking for feedback for the conference. So you can also put there some thoughts for future events. We really thank you all for this. And just to say, it's important for us to keep in touch. Maybe we can have in the chat our email, so from the PAG, for everyone that wants to communicate. So there are many ways to communicate. Just you will find our contacts also there. And thank you.
Thank you very much, Eliza. That was really great and very helpful, I'm sure. And we have a few minutes for questions and answers, and there's many in the Q&As. We can't answer everything now, but we'll try to do it after the conference. And Lucy, there's one I think that is directed to you. And some ask about specific infections with Pseudomonas or with Staph aureus. People have heard these names. And can you say a few words about specific treatments for that?
Sure, I'd be happy to. I'm sorry to hear that I've upset some people from the chat with my food analogies. My intention wasn't to upset anybody, but just to actually have another non-medical way of explaining what I think was happening in people's lungs. So I apologize to those who've been offended by my attempts to level out or reduce the explanations to something that might be more accessible to people who aren't medically trained. The issue around specific organisms is a very important one. So I think sputum cultures are one of the most useful things that the team, that anybody can do when there is a change in symptoms from patients with bronchiectasis. If we know what's growing in the soup, in the minestrone, there we go again, there's my food analogies, in the airways of patients with chronic symptoms, then we can make a very educated guess about what sort of treatments will help when there's a flare-up or an exacerbation. So knowing what's growing in the secretions when you are well helps your clinical team to decide on a treatment, an acute or a treatment strategy when there's a worsening of symptoms. Now, there are some particular organisms or bacteria that do require specific discussion. And I think Pseudomonas is one of those. So Pseudomonas is the name of a bacteria, a group of bacteria who particularly like to move in like squatters in a beautiful townhouse in London somewhere, or maybe in Milan. They like to move in and live in this damaged lung tissue. It used to be thought that they were just squatting, just hitchhikers, just hanging around in a place that was already damaged. But we now understand that like young people having a party, that they're not just innocent bystanders. They are actually these bugs, when they're persistently growing in a damaged airway, are contributing to the ongoing damage in the lung. And so there's a much greater appreciation that if we can possibly eradicate or evict these organisms, then we should have a trial at doing so. There's only once the Pseudomonas, though, has moved in and has been squatting in the abnormal lung for any length of time, and I guess I'm thinking weeks to months, once it's been there for months, persistently growing, it's very hard to evict this organism. But if the persistence of Pseudomonas is accompanied by frequent flare-ups and a heavy burden of symptoms, then consideration for maintenance antibiotics should be offered to patients. And there will always be a discussion between the clinician and the patient about the risks versus the benefits. But in patients with frequent exacerbations, a heavy burden of symptoms, and persisting Pseudomonas aeruginosa, this is the very group who benefit, who have most to gain from consideration of maintenance antibiotics with a specific group of antibiotics, a family of antibiotics called the macrolides. Now, these are things like azithromycin, clarithromycin, erythromycin, roxithromycin. These are the family of antibiotics called macrolides. And this is a group of antibiotics that have been studied extensively in patients with bronchiectasis and frequent exacerbations. And those with Pseudomonas and frequent exacerbations have the most to gain in reduction of flare-up rates. So it's not to kill the bugs themselves, because the macrolide antibiotics do not kill Pseudomonas, but they probably have some anti-inflammatory properties, some other chemical, they have some other effects and other benefits that seem to reduce the inflammation in the airways, clearly reduce symptom burden, and clearly reduce exacerbation frequency. So that's something that you and your doctor might discuss if there's Pseudomonas and frequent exacerbations and a heavy burden of symptoms. Did that answer the question?
You.
Sorry, I can't remember what the question was.
I think so. And I saw another answer about another question about colonizer versus infection. And I think you really answered that question as well. So thank you. And there's one, I think, for Elisa, and this is about recommendations for starting a self-help group. So can you tell about that?
Well, I think it's very important. Actually, in Greece, we haven't a group like that, and we're trying to make one. But sometimes it's even difficult to find others with bronchiectasis. So, for example, myself, I just know 3 people in Greece, and if you had if we were discussing this last year, this time, I wouldn't know anyone. And so it's quite difficult to get in touch. Sometimes I know that other countries have very bigger tradition in that, like the patients have perhaps experience. I know the UK patients are more involved in groups like that. But I think that this is really important. It's important for us to, well, discuss our symptoms, but also to work on issues that we might want in access to medical treatments, in, well, knowing what happens for the future, what happens. Well, we get anxious for many things. This is normal. This is a chronic disease, and we don't have some information on, for example, how it affects other parts of our health, like, for example, the gut symptoms that are common. And so it's important to get in touch and discuss all that. And this is, well, if the PAC can help in that sense, I do encourage everyone to get in touch.
Okay, so thank you to our 2 wonderful speakers for today. Thank you, Elisa, and thank you, Lucy. And I think it's just time to move on to the next session, and we'll be trying to answer all of the questions after the conference. So I'm sorry if we didn't answer your questions now today, but there'll be another chance later on. So with that, I would like to introduce the chairs for the next session, Professor Eva Polverino and Bridget Harris, please.
I think Bridget is on mute.
Hello, I'm Bridget Harris. I'm a member of the Patient Advisory Group and have been since 2015, and it's a great privilege to be part of it and be able to help perhaps a little bit with this condition that many of us have. I live in Edinburgh in Scotland, and I'm a retired nurse. And Eva will introduce herself next.
Sure. I'm Eva Polverino. I'm a pulmonologist, and I work mostly in the field of respiratory infections, and as you can imagine, mostly in the field of bronchiectasis, but also cystic fibrosis. And I'm based in Barcelona, and where I work at the hospital, Vall d'Hebron Hospital. I know some of my patients are connected today. There were particular thank to them who are connected today, and welcome to all of you. Thanks for being here together to discuss this disease.
This session, which is session 2, is about the latest research and improvements in treatment, and it will cover some of the considerable work being done to help people with bronchiectasis now and in the future. And we've now got a poll with a couple of questions for you all. And Claire, if you could launch the poll. The 2 questions are, have you ever participated in a clinical trial? And would you participate in a clinical trial in the future? And you can participate by selecting from the answer options via the pop-up, or click on the link in the chat, or scan the QR code. And we'll see what happens. I think, Claire, we're not seeing the result.
Yeah, sorry, I'm just trying to get the results up. People are answering, so just bear with me.
That's fine. We'll just give it a few more minutes and then see. I think quite a bit of the answer to this will depend on whether you have bronchiectasis or not.
Yes, yeah.
If you're a clinician,
a lot of people is answering on the chat. I think it is more useful if you try to answer through the poll, because so we can measure the answers and quantify them, right? There is you can find a link, right? So we can start seeing.
Oh, that's lovely. That's great. Yes, I think a lot will depend on whether you have a condition that would have made you eligible for a clinical trial or not. But that's I think we'll move on from that now and go on to the talks. Oh, good.
Oh, yeah.
The more, that's lovely. Good. And some people would like to. That's good. That's encouraging. Well, we'll see whether you change your minds after the presentations. So we'll go on to the talks because one of the ways that we can help as patients is to give our support by participating in research when we're eligible. And our first speaker, Barbara Crossley, will talk about her experience of this. Barbara's a writer who lives in the Peak District in Derbyshire in the UK. She's been a member of the European Lung Foundation Bronchiectasis Patient Advisory Group since 2017 and has collaborated with EMBARC researchers in ongoing projects. So over to you, Barbara.
Thanks very much, Bridget. Well, when I asked myself what my motivation is for taking part in a clinical trial, which, let's face it, can be inconvenient and time-consuming, I think about how I explain my particular version of bronchiectasis to the vast majority of people who've never heard of it. I don't say my bronchial tubes and cilia are damaged, which leads to excess mucus and exacerbations. Instead, I say it's like having a permanent chest cold with occasional bouts of flu. But don't worry, it's not infectious. And then they understand and sympathize. And dealing with this permanent chest cold with occasional bouts of flu is why I will sign up to whatever clinical trial will have me, even though I have to travel for over an hour to get to the hospital in South Manchester, and even though the sessions can last anything from 3 or 4 hours to all day. I'm currently on a trial called GREAT2. It's a phase 2 trial for a drug called Gremobermab. This is a monoclonal antibody, which works like the antibodies in our own immune system, seeking out cells we don't want and destroying them. It's a branch of immunology. Gremobermab is targeted on the nasty bug called Pseudomonas aeruginosa, which has been an uninvited guest in my lungs since 2009. Most of the time it's dormant, but when I get an infection, it comes roaring out and bites like a tiger. So my lungs bleed and I feel dreadful. Now, I don't know if I had the actual drug or a placebo during the trial, but I can tell you that it involved 3 intravenous infusions, several weeks apart, 3 or 4 separate visits for blood, sputum, and breathing tests, and a couple of phone calls. And I felt fine. Though I did have an exacerbation between the first 2 infusions, I got better within 10 days without antibiotics, and my normal symptoms improved for a couple of weeks after the 3rd. I was the first person in my hospital to go on this trial. I was fully informed before I went into it, and I felt like a pioneer. Plus, the staff in the research unit really treat you like someone special, and it's great to feel part of the team working to improve treatment for all of us. They pay for travel expenses, and they bring you tea, coffee, biscuits, and sandwiches at regular intervals, so I was happy. This GREAT2 trial is led by EMBARC, which is the European Bronchiectasis Research and Education Network, and it's for patients with Pseudomonas in the UK and Spain. Other recent trials have included Aspen for a new anti-inflammatory called Brensocatib, and coming up will be the Vital B trial, testing an inhaled antibiotic called Aztreonam. So, how do you get on a clinical trial? Well, your consultant or pulmonologist may ask you if you want to take part, or you can search for current trials online and ask them. The hospital itself has to apply to take part, and much depends on whether your hospital has a research unit or whether you can travel to one that has. It also depends on your particular condition. I was not eligible for Brensocatib, for instance, but I was for Gremobermab. So, to conclude, if you, like me, are tired of twice daily airway clearance, nebulizing, nasal rinsing, taking pills and having tubes inserted for antibiotic infusions, all the general fuss and bother of dealing with bronchiectasis without feeling much better, I can only recommend you volunteer for as many clinical trials as you can. The scientists are trying to make things better for us. Let's help them along the way.
Thank you very much, Barbara, to share with us your experience. And you were saying, I felt like a pioneer, or I felt special. You are a pioneer and you are special. You are special to us, doing research. You are special to all the rest of people with bronchiectasis, because you're contributing to advance in the field, to make advance in the field, to find something new for the future. It could be helpful for you, or maybe not to you, maybe to other people. So thank you very much. And I see a lot of hearts coming up. So thanks for your contribution. And then I pass over to Professor James Chalmers. I think everybody knows him, but I think it's important to remind he's the chair of all this, the chair of the MBAC project that started some years ago, and now is a huge project involving many countries, different continents, more than, let's say 300 sites, maybe, James. So a lot of people is contributing, and it was the basement to create all this, including this conference day. So I think it's going to be the time to see what research is doing at the moment, what kind of promises we can get, or what kind of hope we can have from this. So James, the floor is yours. Thank you. And thanks for connecting from Hong Kong. Let's say we are lucky you could connect from such a far place. Thank you.
Thank you very much. And thank you also to Barbara. I think that's the perfect introduction to why we're here today. It's really to give some hope that we will have better treatments than just airway clearance and antibiotics in the future, and to give you some updates about where we are with the progress of science in this area. Lots of people working together to try and find better ways of managing and treating bronchiectasis. So before we begin, I do a number of research studies. Some of those studies are funded by government, some of them are funded by the pharmaceutical industry, and I'm going to talk about treatments that are in clinical trials. So none of these are treatment recommendations. You should always talk to your doctor about any new treatments that you're considering. Many of you will be parents. I'm a parent of 3, and I've recently had the Disney experience, and I was thinking about our wishes and our dreams about bronchiectasis research for the future, and thinking about this recent film. In this film, everybody gets very frustrated because the king takes everybody's wishes and only grants the wishes very rarely. And sometimes research feels a bit like that, because there's lots and lots of research going on, but we wait a long time for new treatments and new information to come through to us, and it can feel a little bit frustrating and a little bit detached, I think, from the patients. And so I thought it would be really nice to go back in time a little bit and ask, what do we know about what bronchiectasis patients' wishes are when it comes to research? What do you as patients, what have you told us that you want to know about? What did you tell us that you wanted to research? We did a survey with the European Lung Foundation of 711 patients with bronchiectasis all across Europe back at the beginning of the EMBARK project a few years ago now. And this asked questions like, what are the most important problems that you have with your bronchiectasis, and what research questions do you want us to answer? And we came out with a series of very important questions that have informed what research has been going on over the past few years. And I hope you'll agree that these 4 questions are really important. These are 4 of the top-ranked questions from you, the patients. And the questions were, what causes bronchiectasis? That was the one that was ranked number 1. Why do some patients get worse over time? What causes exacerbations? And of course, can we find better treatments and different ways of managing the condition? So I thought today I would give you an update on where we are with research into all 4 of these different questions. So we'll start with what do we know about what causes bronchiectasis? And here, I'm hoping you'll be able to do a little poll for me. If you're a patient with bronchiectasis, do you know what caused your bronchiectasis? And I've given you 4 options. The first is yes. The second is maybe. The third is no, and you've been tested, but the cause wasn't found. And the fourth one is no, and you don't think you've ever undergone tests to find out why you've got bronchiectasis. And let's just see if the poll comes up. I'm not seeing the results of the poll at the moment. There we go. And we'll just give this a few minutes. So this is exactly what I was sort of expecting, a mixture of different answers. Some people saying that they know, many patients saying that they don't know at the moment. It's about double the number saying one of the 2 no answers. So this remains a really important question, doesn't it? We want to know why so many people have got bronchiectasis, and it's important to note lots of people there saying that they've had the tests, but the answer is no, but some people saying that they've not undergone testing for bronchiectasis. Okay. How do I close the poll? There we go.
Yeah, you'll need to reshare your slides, James. Sorry.
No problem. There we go. So when we exactly what we saw in the poll is what we would expect to see when we've studied people with bronchiectasis, and we've now got a very large registry with nearly 20,000 people who volunteered very kindly to let us have their information on that registry. The cause is unknown in the majority of patients. So that's something that we really need to address with research. That big blue part of the pie chart is idiopathic, which is the medical term for we don't know. And that's still the largest group that we see. But there is research going on in this area, and that's really exciting. And Barbara talked about participating in clinical trials. But participating in research isn't just about participating in clinical trials. Sometimes participating in research can be as much as just donating a blood sample or donating some of your information to the medical professionals. And nearly 2,000 people with bronchiectasis have now donated blood for genetic testing to try and find out the causes of bronchiectasis as part of this EMBARK project. And this is revealing that in some people, we can find the cause, and there's a genetic cause of bronchiectasis where the cilia, the hairs that you've already heard about today during Lucy's presentation that clear bugs from the airways. There's a video here of how those hairs clear mucus and bugs from the airways. In this genetic condition, these hairs don't work, and so people develop bronchiectasis. And it's something that's quite difficult to diagnose, and so it's often missed. And so by looking at the genetic code that we can get from people's blood samples, 2 studies have recently been done that have looked at how often we can find this one genetic cause in people with bronchiectasis. And those 2 studies found first that 1 in 8 people with bronchiectasis had this condition. That was in a study looking at people with quite severe bronchiectasis. And in another study, 1 in 20. Now that's really important, isn't it? If there's 500 people on this telephone call today, it means that a significant number of them may have a genetic cause that wasn't suspected, because these studies were all conducted in people who didn't know that they had a genetic cause of their bronchiectasis. So genetics is leading us towards a better understanding of what causes bronchiectasis, because that's only one type of genetic bronchiectasis. The studying the genome in bronchiectasis will help us to find known genetic causes of bronchiectasis, like cystic fibrosis and primary ciliary dyskinesia. But it may also find new genetic causes that haven't been suspected. And because it helps us to understand the disease better, it will also help to develop new treatments, even for people that don't have a direct genetic cause of their bronchiectasis. And so, again, participating in research can make a really big difference, even if it's not participating in a clinical trial. Even just donating a blood sample can make a huge difference to understanding the condition. So we're learning more about what causes bronchiectasis and finding new causes and unrecognized causes of bronchiectasis. What do we know about why some patients get worse? And I'm not going to spend a lot of time on this because Lucy addressed some of this during her presentation. It's about inflammation. Our research suggests that when the airways get damaged, you get these white blood cells called neutrophils into the airway. There, you will recognize them if you're a patient with bronchiectasis. These cells create a green color, and so when your sputum goes green, it means that you've got more of these inflammatory cells in the airway. And when people get chest infections, they'll often say that the sputum becomes more green, and that's a sign of more inflammation. The inflammation, the white blood cells, cause the body to make more mucus, and they cause a lot of the problems that we talked about earlier during Lucy's presentation. What our research has now shown is that measuring this inflammation, people who've got more inflammation have more exacerbations and more symptoms. And so it's really identified trying to dampen down this inflammation as a key way of treating bronchiectasis. We have some treatments already that we've discussed, like macrolide antibiotics, which are anti-inflammatory treatments, but it would be really wonderful to identify better anti-inflammatory treatments. And I'll talk about that, some really exciting news about that in the next few slides. What about what causes exacerbations? Lucy talked a lot about exacerbations, but they're very different between different people. Do we know more about what causes exacerbations? We think a lot of them are caused by bacteria in the lungs, but we've learned something from the COVID-19 pandemic that I think is really important. During the COVID-19 pandemic, everybody wore masks. People didn't go out as much as they used to. They didn't see other people as often. And the result of that was there was a big reduction in the circulation of viruses like the common cold virus and the flu virus. And so we've been studying what happened to people with bronchiectasis during the COVID-19 pandemic. And it's really amazing. During the COVID pandemic, so during 2020 and 2021, data from Europe shows that the number of exacerbations overall went down by almost half. And in the United States, another study showed that it went down by almost half. So the fact that two studies show this makes it seem very much like this is correct. And I wonder if some of you experienced that your bronchiectasis flare-ups reduced during the COVID pandemic. What this tells us is that about half of bronchiectasis exacerbations are probably caused by viruses that circulate between ourselves, like the flu virus and like the common cold virus. And so this tells us something about how we prevent exacerbations. Often when we talk about preventing exacerbations, we're always talking about drugs. But maybe some simple measures to avoid exacerbations that we've learned from the COVID-19 pandemic can help us, like keeping away from people who've got a runny nose or a common cold, eating a healthy diet, keeping warm, and avoiding infection in that way. So we've learned more about what causes exacerbations, and this is stimulating research into treatments that can prevent viral infections, as well as all of the treatments that we have to treat bacterial infections. And so again, we're learning more and developing better ways of treating. But what we really want are new and better treatments for bronchiectasis. So where are we with new and better treatments? Well, again, going back to this analogy of the wishes, the frustration is that it often takes a long time for treatments to come through to patients that are in development. Again, this king who holds the wishes and never releases them to people is the bad guy in the film. And the reason why is that you have to go through phase 1, phase 2, phase 3 trials and other types of research before you can get treatments into the hands of patients through health services. And so it takes on average 10 to 15 years for new drugs to reach patients. But I've got some really good news for you, that there are some drugs that are coming through very soon, but also there are ways of shortcutting that 10 to 15 years. Many of the drugs in your drug cupboard at the moment or in the pharmacy that are used to treat other conditions like cardiovascular disease or rheumatological conditions also have effects that might be of benefit to people with bronchiectasis. This taking a drug that's used for one thing and using it for another purpose is called repurposing. And there's many well-established safe drugs that might have a benefit for bronchiectasis that are used, for example, for conditions like asthma or rheumatic conditions. And so I'm very pleased to let you know that there's going to be a new large investment into a clinical trial in order to test repurposed medicines in people with bronchiectasis that's going to be kicking off this year. And that's really exciting because it should cut that 10 to 15 year timeline for new medicines by at least half. Now, there's a new, I mentioned earlier that anti-inflammatory treatment is really what we would want because we know that inflammation is what causes patients' disease to get worse over time. A new treatment, which is called a DPP1 or cathepsin C inhibitor, which is an anti-inflammatory treatment that targets those white blood cells, the neutrophils, is now in late-stage clinical trials. In the phase 2 trial, which was conducted in 256 patients across the world, you can see on the left-hand side the levels of lung inflammation in the blue and the green lines went down dramatically in people who were taking the drug. This is in sputum samples. And that this translated on the right into fewer people having chest infections. Around half in the placebo group in the black had chest infections, and that was reduced in the blue and the green line with the people who were taking this medication called brensocatib. This is a treatment that's not an antibiotic that directly targets the inflammation in the lungs and reduces the inflammation in bronchiectasis patients' lungs. So that's really exciting. There's now 3 trials of different types of this anti-inflammatory medicine going on. The question you want to know is, when is this wish going to come true? And when are we going to get the results of these treatments? And the good news is the answer is this year. So the ASPEN trial is a phase 3 trial. That's the last stage of development before treatments can become available to patients. This is a trial of 1,600 patients with bronchiectasis all across the world, testing this brensocatib at 2 different doses. And this trial is due to complete and is due to give the results this year. So 2024 is a year when we will get the answer as to whether anti-inflammatory treatment is going to make a difference for patients, and we all have our fingers firmly crossed. But it's not the only trial that's going to report this year. We're going to also get the results of another cathepsin C DPP1 anti-inflammatory treatment. This is now called the AIRLEAF trial, and this is also completing this year and will give our results in the summer. And so in the dream scenario, we may have 2 anti-inflammatory medications giving results this year and hopefully positive results. Barbara told you about the GREAT 2 trial, which was a trial of antibody treatment. Antibodies are illustrated in the bottom left here. Unlike antibiotics, which wipe out everything that's there, including good and bad bacteria, antibodies are precision targeted, so they only bind to the bacteria that they're trying to target. And so we hope may be more effective and perhaps have less side effects than giving broad spectrum antibiotics that many of you will be used to. The Grade 2 trial is again a trial that's been conducted over the last year. It's recently finished enrollment and will give its results this year. So it's really great to be able to be in a position to say to you that we're not holding all of this research, all of these wishes back, and not releasing the results. We're at the position where we may be able to give a lot of hope in 2024 to patients with bronchiectasis because we have so much research that's due to give its results later this year. Of course, we can't promise to make all wishes come true because clinical trials can be positive and can give positive results, or they can show that things don't work. And so we just have to keep our fingers crossed and keep making our wishes and hope that the research gives us the exciting answers that we really want. What I've hopefully given you is an idea of just how much is going on. The 3 trials that I've shown you are not the only trials that are going on. There are dozens more that are trying to find new treatments for people with bronchiectasis. And it's really an exciting time with a bright future. There are new treatments for inflammation, and I believe this year we will get the results, and I really hope that they show us that we will get our first effective non-antibiotic treatment for bronchiectasis. We're finding new alternatives to antibiotics like the antibody treatments, and particularly for Pseudomonas, which is such a difficult problem for so many of you. And as I've shown you, there's better tests coming and ways to find the cause that will also help us to develop new targeted treatments, because there are, of course, ways to fix faulty genes now. And so if we can find the genes that cause bronchiectasis, we can start to find ways to also find targeted precision treatments for people with certain types of bronchiectasis. So I wanted to say a massive thank you to everybody who's participated in research. I told you about trials there of 1,700 patients, genetic studies of 2,000 patients. These things are only possible because so many wonderful people with bronchiectasis volunteer to participate in clinical research. And as I said to you, if you're watching this presentation and you've not done research before, getting involved in research can be as simple as allowing your data to be used in a registry or donating a blood sample. It doesn't always have to be a drug trial. And so do please consider whether you could contribute to research. I want to thank EMBARC and the European Respiratory Society, as well as the European Lung Foundation, who've contributed to so many of these clinical studies and clinical trials. Our partners who are helping us to do all of this research and funding all of this research, and the team that we work with at Dundee, all of my friends and colleagues. Thank you very much for letting me speak to you today.
Thank you very much, James. As always, a really interesting presentation. And speaking as someone with bronchiectasis, it's full of hope for the future. So much has been done over the last years compared to the dearth of information before, and more is happening, as you have pointed out to us. And we're very grateful to you and all of those involved in bronchiectasis research and improving our condition. And our next speaker is Sanjay Chotimal from Singapore. He is an internationally recognized clinician scientist with a research group at the Lee Kong Chiang School of Medicine in Singapore, where he's also Vice Dean of Research. His work's been published in a number of prestigious publications, and we look forward to hearing what you're going to talk about, Sanjay.
Thank you so much, Bridget, and thank you to the organizers for inviting me. I feel like this is my most important talk of the year. I speak at lots of scientific conferences, but as a mentor taught me when I was training in respiratory medicine, research exists for patients and not vice versa. So I'm extremely privileged to talk to this group today. So I'm going to take a slightly different approach to James, who I thought would tell you all about the treatments in bronchiectasis and talk to you about some of the scientific approaches we use to actually understand this complex disease. I'm, like Lucy, going to use some analogies, and some are going to be food, but hopefully not too disgusting. But I'm also going to use a whole range of everyday analogies to try and make things that are relatively complex as simple as possible. And if I do veer into more of a scientific realm, then I do apologize. These are my disclosures. And so to start, I think the first question is, why do we need new approaches, and why do we need specifically individual approaches to studying the science of bronchiectasis? And really that's because each of us are unique and each of us are very different. And what that means is that each of us has very specific needs. Our needs change over time, and they change as we get older or as our life circumstances evolve. And so really we do need that personalized approach in the way we treat patients, and therefore we need that personalized approach in the way that we do science to inform the disease. So the term precision medicine has been used widely, and many of you would have heard about it in the newspapers and otherwise. So what does that really mean? So I've taken two everyday examples to try and explain what that actually means. And the first one is when you go to the tailor's and you get a set of clothes made, in this case, a gentleman getting measured up for a suit. That suit will solely fit that particular individual. It's measured for shape, size, every aspect, and it's tailored to that individual. In the same way, all of us use GPS navigation to go from one place to another, whether by car or even by walking. And what these systems do is they take into account where you are at a very specific place and point in time, the surrounding conditions at that time, and give you the best route to the destination that you've put into the system. So that's a very individualized way of providing instructions for you. In the same way, we need to approach the treatment of various diseases based on individuals, and we need to tailor our care to the individual at that point in time based on their needs. And that's what precision medicine is really focused on. I'm going to use a term called multi-omics in this talk, and multi-omics is a very fancy term for something that I'm going to explain in a relatively simple way. All of us have used cookbooks in the past, and these books are full of recipes that cook a whole range of dishes and foods. And really, what is the cookbook of us as humans? Our cookbook is our genes, our DNA, and we call that genomics when we study that. And so you would have heard of lots of scientific studies that are focused on genes, genomics, and DNA, and that's one of the multiple different omics, which is multi-omics. When those genes are modified in a specific way, we call that epigenomics, and there's lots of epigenomic studies that exist in the scientific literature. However, a cookbook is a book that tells you how to cook the infinity amounts of recipes that we could cook. We've got to pick the recipes for specific purposes. And so if you pick a specific recipe from a cookbook, we get specific instructions to tell us the dish we've chosen to cook. And in the same way, our body has in lots of thousands of functions, and so it needs lots of instructions, very specific instructions, in order to cook the right dish for the right purpose. And those individual recipes are called transcripts. And so the multi-omics method of studying transcripts in the human sense is transcriptomics. However, the recipe doesn't cook the dish. And so once we've got the recipe, we've got to get a whole range of unique ingredients, which can be of a huge variety. We have a whole range of cuisines all over the world, and we cook up these dishes that then we enjoy. And so the genes is the cookbook, the transcripts are the recipes, and then everything else is the actual food and the molecules that are used to do the functions that our body needs to undergo. So when we study proteins in the body, we call that proteomics. When we study metabolites, which are breakdown products, we call that metabolomics. And when we study fats or lipids, we call that lipidomics. So the word multi-omics really incorporates all of these different omics, whether that's genomics, transcriptomics, proteomics, or many others. So I come back to my original question of why we need individual and why we need new approaches. And really, we know that in bronchiectasis, we have a very heterogeneous disease population. Patients are quite unique. And if we use the processes we've used in order to diagnose and manage them, we end up with subgroups of patients, whether that's patients with Pseudomonas, patients with frequent exacerbations, etc. And perhaps that's not detailed enough. And that's where multi-omics can come in. So we know what the clinical scenario looks like and what a patient presents with, and we call that a clinical phenotype. That is, for example, patients who frequently exacerbate may be referred to as frequent exacerbators. But not all frequent exacerbators are driven by the same mechanisms between each other. And that's where multi-omics comes in. Multi-omics can help you understand mechanisms that are driving disease and point us in specific directions that may uncover new pathways that we previously did not know about that could potentially open the avenues for targeted treatment. And we call those mechanisms endotypes. And so patients with a specific clinical phenotype or the way they appear can have multiple mechanisms driving their condition in bronchiectasis and therefore multiple endotypes. But at the same time, a single mechanism may be present in multiple phenotypes. So it's very useful to use multi-omics to subgroup patients into different groups where we can give very precise targeted treatment, which would work in that group and not necessarily in another. So that's, this slide summarizes some of the terms that I've talked about, which is the phenotype, which is the clinical features that patients may commonly share. We can divide that into subgroups called subphenotypes. We use multi-omics in order to drive the understanding of mechanisms that are driving that. We call those endotypes. And when we know the mechanisms that are driving the clinical scenario that we're seeing in the clinic, we can come up with what we call treatable traits. For example, patients with a particular type of inflammation, as James has talked about, neutrophilic inflammation, may be targeted by these new anti-inflammatory therapies that James talked about, these DPP-1 inhibitors. But it's important to appreciate that what I've talked about already with this multi-omics concept is that they're multi-layered. Remember, the cookbook gives you the recipes gives you the various types of food. And so we do need to look at this holistically, because no one omics is going to tell you the overall story. So now I'm going to move into how I think these scientific approaches can actually help us in the clinic and help us in bronchiectasis. Now, unfortunately, I have to use examples that are outside bronchiectasis because I think in the last decade, the science of bronchiectasis has really started to gain momentum, but we're still several years behind some of the other respiratory conditions. So this is a concept paper that James and I put together a couple of years ago, where we tried to map the different parts of bronchiectasis, whether it's the underlying cause, the way your CT scans look, the types of bacteria you have in your lungs, the clinical phenotypes that I talked about, the types of inflammation you have in your lungs. And we tried to map that against the different causes of bronchiectasis here. And really what I want to get across from this image is that it looks like an underground tube map. And that tells us that this is not a simple one-to-one relationship. It's a very complex relationship. And again, promoting the fact that we need to take individual approaches. Just putting people into bigger groups, it may not be effective in bronchiectasis. And that's where these multi-omic technologies come in. They're going to help us resolve this disease heterogeneity that exists in the clinic. That is, one patient is totally different to the other in terms of what's driving their disease. In fact, already we have shown that using these approaches tells us about different subgroups of bronchiectasis patients. In this particular study, we found patients who have sensitization to fungi very different to patients who have sensitization to house dust mite in the types of inflammation that existed in their lungs. The EMBARK group has published a recent study that has shown us that not all bronchiectasis is dominant with neutrophils, the major inflammatory blood cell, but in fact, up to 1 in 5 patients have eosinophilic inflammation. What do we mean by that? It's a cell that's involved in a more allergic tendency and therefore may need to be completely differently approached from a treatment perspective as compared to the neutrophil dominant disease. So I think multi-omics is going to help us identify new phenotypes and get them understood by the mechanisms and endotypes that we do not appreciate at present. This is already something that's going on in other respiratory diseases, and this is just a complicated side to transmit a very simple message, because in COPD, this has been incredibly effective. In COPD, multi-omics has generated a whole range of understanding of different subtypes of disease that now can be independently treated. They did exactly the same thing in severe asthma many years ago through a European-wide consortium called EuBioPred, where they recruited patients from centers all across Europe, took a whole range of patient specimens, whether that's blood, sputum, and even urine, and then did what we call omics data acquisition, which is the multi-omics I've just spoken about, integrated that data and created what they call the handprint of asthma. Just like fingerprints are very unique to each individual, the type of omics makeup and the signals that we get from that omics analysis are quite unique to the individual bronchiectasis patient. And in fact, this is a gap that EMBARC, under the leadership of James and colleagues, has already made huge strides. In fact, now in its third iteration, the next phase of EMBARC is actually to delve much deeper and use the biobanks that have now been created with thousands of patients being involved, many of you on this call, I'm sure, and thank you for that, in order to leverage those specimens, understand the clinical context, and then apply these multi-omic technologies. Here's a different example from severe asthma, where we looked at the recipes or the transcripts, all right, in the EuBioPred project. And what you can see here along this axis is the different types of inflammation, whether that's neutrophils or eosinophils that I just mentioned, that have just been shown in bronchiectasis, a mixed version or lack of cells. And what they did was they looked at transcriptomic profiles, or what the recipe pages look like. And they found 3 different groups, TAC 1, 2, and 3. And if you look, different TAC profiles were present across different types of inflammation. Again, reinforcing to us that this is a very complex relationship. I want you to keep this particular example of TACs in your mind, because in a later slide, I'm going to revisit it and tell you something new. So how else can this approach help us in the clinics? Well, it can help us identify things much more easily, whether that's by sputum, by lung washings or bronchoalveolar lavage, or even exhaled breath. We can apply multi-omics now with the technologies that we have to all of these patient specimens, and in fact discover new markers for whether that's diagnosis, treatment response, or even prognosticate and see which patients may deteriorate before they do, which allow us a window of intervention. So really, biomarker discovery is an important benefit that I think these omics approaches are going to help us with, and particularly so in bronchiectasis. But as I mentioned at the start of the talk, omics are going to tell us about new mechanisms, new aspects of the disease that are being driven in specific patient groups. And this is an example, again, of a multi-omics studies where they looked at infection, they looked at metabolomics, they looked at proteomics, and they looked at the recipe, the transcriptomics in COPD. And even now, despite the advances in COPD, they're able to discover new mechanisms. So these are very powerful tools that we now need to apply to bronchiectasis in order to give us that understanding that we need that can help us develop new targets and new treatments. So precision medicine, which I explained at the start of the call, at the start of the talk in terms of tailoring a suit or your GPS, has already been incredibly successful in cystic fibrosis. Cystic fibrosis, which is a predominantly genetic disease, has a whole range of genetic mutations that can cause it. But now there are specific oral therapeutics that can target the basic genetic defect. And so the technologies exist for us to apply precision medicine even to diseases that were previously thought to be incurable. So really, this is about hope. This is about the technologies advancing so significantly, and now us having the infrastructure and resources through EMBARC and others to be able to access the bronchiectasis specimens that we need to apply all of this science. Another example of precision medicine operating in everyday clinics all around the world is in severe asthma. Severe asthma has lots of different inflammatory pathways. And every step of those various pathways can be targeted by individual drugs and agents, which we call biologics. That has revolutionized the care of asthmatics. And so when your doctor tells you about precision medicine, we're already doing this in asthma, in COPD, and we now need to do this in bronchiectasis. An example to add on to what James has already explained very well is, in fact, studies by James and other colleagues have already shown that neutrophils were really important in bronchiectasis far before the therapeutics to target them were being trialed and tested. And so identifying that endophenotype, as I explained at the start, resulted in a therapeutic target. And in fact, as James says, more than one drug is now in clinical trials. And hopefully this will be the year where we get that first non-antibiotic therapy for bronchiectasis. So this is already at work in bronchiectasis, but we can do more. Another aspect that I think that these technologies really help us with is in understanding when patients have more than one disease. I've seen in the Q&A and in the chat that's gone on since the start of this conference, people talking about, what if I also have COPD? What if I also have asthma? This is where multi-omics can tell us what aspect of your disease is potentially predominant and how we should treat you best. And so again, there's emerging data to suggest that applying multi-omics is going to give us real advances in that overlap disease state. And of course, omics help us prognosticate, predict, and we can identify patients that have a higher risk of progressing. This allows us to see you more often, to identify and intervene with treatments earlier, among other clinical interventions. So this is a really important and powerful set of tools that we need to apply in bronchiectasis in a much more significant way that we already have. Of course, as with everything, there are challenges to bringing this to the bedside and to the clinic. Cost is something that every healthcare system will talk about, but you've also got to have the facilities to process it. We need to integrate this multi-omics data with your electronic health records at your individual hospitals. You need to have specialists that understand how to perform and interpret this complex information. We need to understand how to interpret the data that we generate. We need it to be standardized. The same experiment in a country in Europe, as well as a country in Asia, needs to be done and processed in exactly the same way. And we're now undergoing clinical utility studies and validation in order to show that these interventions or these scientific experiments are actually consistent between various locations and various labs. Nothing can come into clinical practice unless it is strongly and robustly repeatable. I'm going to spend the last 5 or so minutes telling you about how I think this field is going to move and where I think it's going to move in bronchiectasis. So I think, again, multi-omics has been really important for all the other respiratory diseases as it's becoming in bronchiectasis. But in fact, identifying bronchiectasis earlier is going to give us huge therapeutic benefit. Identifying it earlier allows us to intervene earlier and allows us to stop the progression. This is already at play in COPD. There are lots of international studies ongoing in recruiting early COPD cohorts and groups of patients. And perhaps we need to move into this direction in bronchiectasis in order to understand the natural history and evolution of the disease to answer the first question that James put up in his talk, which is what's causing my bronchiectasis. By understanding that at the earliest stage, we're going to be able to hopefully crack this in a better way than we are now. And remember, I talked to you about the TACs in severe asthma, and I asked you to recall them. Well, here, when they did that original study, they then repeated it several years later, and they found that the TAC profile at a specific point in time changed as patients with every year that passed, which means it's not as simple as just applying multi-omics at a specific point in time. We need to do that in a repeated fashion, longitudinally, and understand, in fact, how patterns will evolve in order to be able to apply that precision medicine to bronchiectasis. And then finally, as I said, it's not just a single omics view that one can take. And another analogy that I like to use is one of a Rubik's Cube. I'm sure many of us have played with this as a child or even an adult. And I see a solved Rubik's Cube as one of a patient who is quite stable. And a scrambled Rubik's Cube is one that is undergoing an exacerbation, progressive, or is active in their disease state. In order to solve a scrambled Rubik's Cube, you need to appreciate what's on every other side. And in order to do that, you need to take a holistic 360 view of the patient, and that means multiple omics, not just a single omics. And so that's the challenge here. We have lots of science that is happening that is looking at single omics, but we need to move beyond that into multi-omics and integrating that data in order to give us that holistic view of a single patient. And then finally, this very complex slide is to really, again, tell you a very simple message, that the technologies are continuing to advance. We now just don't even get recipes at the transcript stage. We can go down to single individual cells and study how the recipes are different between the various cells, even if they're the same type of cell. And that's called single cell transcriptomics. We can also identify exactly those recipes in the locations within the lung, whether that's at the surface of the lung, in the muscle, in the blood cell, and that's what the spatial part of the transcript will tell us. So really, will precision medicine and omics help our bronchiectasis patients? I think they already have, in the sense of what James has talked about today. An endophenotype of neutrophilic dominant bronchiectasis has been identified as therapeutically targeted in now a phase 3 trial that will hopefully report positively at the end of the year. But again, this is increasing and we still have lots of work to do, especially on early disease. Each of us physicians are already using precision medicine in everyday practice, not necessarily in bronchiectasis just yet, but we're getting there. We do have to tackle the key challenges, which is equitable access and affordability of being able to apply these approaches, but these emerging technologies are getting more and more powerful that we really have an opportunity now to resolve and demystify this heterogeneity that exists in bronchiectasis. So I'm going to stop there, but I hope I've been able to achieve getting across to you that the science in bronchiectasis is certainly moving in the right direction, and we have lots to be excited about. Thank you.
Thank you very much, Sanjay, and thank you for sharing with us all this information about research, what we could get in the future, all the new tools we have, because it's a lot about new tools that will possibly contribute to better understand the disease and to get a more personalized treatment. At the end of the story is what we need, a specific treatment, an individualized treatment for each of our patients. So thank you very much to both of you, James and Sanjay. There is a lot of discussion, a lot of questions. We try to answer some of them, but we picked some of the questions because we think that it's very important to discuss them with all of you. So I selected some questions for James and some for Sanjay. The first one would be for James, and I know you will like this, because somebody is asking about the role of neutrophils in the context of exacerbations. Can you explain us a bit more about these cells?
Yeah, absolutely. So Eva's saying I like this because this is my favorite cell. I'm a bit of a science nerd and I do love the neutrophil. The neutrophils are white blood cells and they're kind of the policemen of your body. They go around and try and mop up any damage that's happening or battle any bacteria that are around. And so they go into areas of the body where they detect a problem. And obviously when there's bronchiectasis there's a problem, and they cause that green color to the sputum and some of the symptoms that patients have. And so a lot of the symptoms that you will have as a patient, like coughing up lots of sputum, is because those neutrophils irritate the airway and cause the airway to make more mucus. And that's why it's important that we try and develop treatments that can target that, because most of the treatments that we have at the moment suppress the disease for a while, like antibiotics do, but they don't break that cycle of inflammation. They don't completely remove the inflammatory problem that's in the lungs. And so that's why it's exciting that there's treatments coming that target these white blood cells that would allow us to treat the disease without using antibiotics or using antibiotics less.
And I think there was another question that was directed to Barbara. about exacerbation? How do you feel when it is the time to take an antibiotic or to do something else to contact your doctor? How do you manage that?
What about deciding when to take antibiotics? Well, I try to resist taking antibiotics unless I'm really, really ill, because I am concerned about antimicrobial resistance. And also from past experience with my particular bronchiectasis, I know that it will usually resolve itself within 10 days, like anybody else getting an infection. If I can just power through the first few days, it'll get better itself. But that's me. Everybody's different. You know, other people would react differently. So my personal response is based on past experience and the consideration of antimicrobial resistance.
I think what you just said is very important, because it's you and it's your past experience telling you that you can wait up to 10 days, try to manage your infection, because you know you have a chronic infection. You said you have Pseudomonas aeruginosa since many years. So when you already know there is a chronic infection, chronic symptoms are there, sometimes they go up, and you possibly are able to manage those symptoms, or you know when you can wait or when it is a clear exacerbation. The point is to understand when you pass the limit and then it is a clear exacerbation. Am I right? But there is a process that is like, you need to learn about your disease, about your symptoms, understand. You need to learn how to listen to those symptoms. Am I right? I think that is very important. It takes a while, is it?
Yes. You learn your own baseline symptoms, the quantity of sputum you bring up every day. If that varies, then that's a signal. And also hemoptysis, which I get from time to time, that's a signal you've got a serious infection. So yeah, if I do have serious hemoptysis, I will take them. But really, there's only one oral antibiotic that works for, well, it's supposed to work for Pseudomonas, which is ciprofloxacin. And I've found that it's not that effective, to be honest. It really isn't.
It is not anymore at this time, because you have been on with Pseudomonas since many years. So after many times you use it, the sensitivity to this drug falls clearly and dramatically, right?
But I rely a lot on airway clearance techniques. I take them seriously. I do them twice a day, and I'm strenuous with them. I take at least half an hour each time with them. And it really is a lifesaver for me. I wouldn't be able to manage without doing that every day.
And do you find, and maybe Bridget can also answer this question, do you find it useful to increase it when symptoms go up? Is that useful to you?
Well, it increases by itself anyway, because you're producing more sputum.
Definitely.
So it lasts longer.
This is what we call patient's empowerment. They are able to listen to their body, to intervene, to do their best to manage their symptoms, unless there is anything else that should be done by the doctor. Thank you very much.
So well, even recently, I'm still learning. I had a recent session with a respiratory physiotherapist, and she taught me the technique of autogenic drainage. And I found that really effective. More effective than the active cycle of breathing, which I was using previously. So you can still learn, even though I've had bronchiectasis all my life.
There are plenty of different techniques. The important thing is to find what you find useful for yourself. Bridget, your experience in that?
Yes, I'd endorse all that Barbara has said, 100%. And it links to some of the questions in the Q&A. There was a question on how often should you do chest clearance. You really need to monitor your own condition. Even if you keep a chart and do that, it can be helpful. And you need to ideally have a consultation with a physiotherapist who specializes in chest conditions, who will teach you different methods of air clearance and try and find one that suits you And you might use a different one if you have an exacerbation than if you would use day to day when you're not too bad, perhaps. But learning your condition and trying to learn more about it is really important, because ultimately it's down to you how you get on with it, and you can't just ignore it and hope it will go away. And it is very difficult in certain countries and even certain parts of countries, because there isn't necessarily the specialist help you'd really like. But there are support groups in many countries, and that can help. But try and learn what you can about your condition, and do be vigilant with airway clearance, because it really does help, even if it's a pain in the neck, to do it.
Becoming more autonomous, it is key in a long-term condition. So we're talking about green sputum, we're talking about expectoration, but airways starts in the nose, and many people are asking about the connection between sinusopathy and bronchiectasis. And as James was talking about causes, can you explain us a bit more about this connection? So there are at least 2 or 3 questions. Are they connected? How should we manage if there is an infection one side? Is this affecting the lungs and reversely?
Yeah, so about 70% of people with bronchiectasis will also complain of symptoms in the nose. It's really, really common. And it's because the airway tube, if it goes right from the tip of your nose down to the air spaces where the oxygen is exchanged, all of that is your airway. And so the inflammation that happens in the airway in bronchiectasis can affect you along the entire length of the tube. There are certain conditions like primary ciliary dyskinesia, which I mentioned during my talk, where the cilia don't work, and so they don't work in the nose the same as they don't work in the lungs. But in most people with bronchiectasis, that isn't the cause. In most people with bronchiectasis, it's the inflammation that's the problem. And so an important thing for us to remember as doctors is that if you don't treat the inflammation in the nose, if you only focus on the lungs, there's untreated inflammation there that's allowed to get out of control. And so we often, or I always teach when I'm teaching about the management of bronchiectasis, that you have to treat the whole airway, which means also helping to treat the nose with the management of chronic rhinosinusitis.
So I would pass to Sanjay, because somebody was asking about the role of fungal infections and their role in terms of inflammation and exacerbations. What do we know about that?
So that's an excellent question. In fact, I think the first point to make is that was a question patients wanted answered, because in the research priorities paper that James showed as part of his talk, in fact, understanding the various fungi in bronchiectasis was something that did come up. A couple of years ago, we did a study where we looked at the types of fungi that exist in the airway of patients with bronchiectasis, and we found some interesting patterns. And what that tells us is 2 things. One is that we're very used to thinking only about bacteria. And so quite rightly, that question is being asked, and we think less about fungi. Now, fungi can do several unique things. And again, a way a fungus behaves depends on the underlying immunity that the patient has at the time. So, for example, somebody receiving steroids for whatever reason, whether that's part of a chemotherapy regimen or something else, will change your underlying immune function. Why is that relevant when we're talking about fungi? Is because fungi, when your immune system is diminished, even for that period of time, are more likely to cause an actual infection. However, on the other side, when your immune system is more overactive, perhaps even, patients who have more of an eosinophilic bronchiectasis type, for example, you may start to see sensitization or allergic type reactions in the lung, which are asthma-like symptoms. So the fungus is not causing the infection in that sense. It's causing a reaction, which is giving you symptoms. So your body's reacting to it. So I think fungal infection in general is complex in itself. And when you mix it with bronchiectasis, that's even more complex than than without bronchiectasis. So I think after all the other traditional bacterial sources have been excluded, it's important that we screen for example, ABPA, that again came up in the chat in earlier session. I think every time I have a new diagnosis of bronchiectasis, I will always screen for that. But it's important that that then is repeated at a later time point. Because again, just like Pseudomonas likes to harbor in lungs that are abnormal, some certain fungi like to do the same thing. And the status at the start may be different to the status in the future. So I guess that's probably the appropriate answer to that question.
And many patients were worried about humidity and environmental conditions, how these are related to fungal infections, for example, to allergies.
Yes, so that's a major problem where I'm based, right? So I'm based in Singapore, which sits right on the equator. Our humidity levels are really high, and many patients will have mold in their homes by no fault of their own. It's just if your windows are open all the time and it's humid, it facilitates that. So I think that is a really important point of exposure, and especially in people who have bronchiectasis or any other respiratory conditions, we do warn them about making sure that they're checking and cleaning up all aspects of mold and mold exposure. And in humid conditions, the risk is somewhat higher. So you do have to be vigilant. And again, just as Barbara said earlier, you need to know yourself. There are some patients that are really sensitive to this and some patients that are less so. And I think once it's happened once, you need to recognize that yourself. And even if you're in a foreign country on holiday and in front of somebody who's not familiar with your conditions, actually you are the expert of your own bronchiectasis.
Yeah, I've been asked this kind of question many times. What should I do with humidity? And I say some people are very sensitive to increased humidity and they get bronchospasm. So some others find it beneficial because this is increasing humidification of their secretions and find expectoration easier. So it's very relative, but in general, when we're talking about excessive humidity, we're talking about very high humidity. It's not something that you find everywhere. That's the reason Sanjay is telling us. In Singapore, we have very high humidity. It's not the same as living in France or in Germany. So imagine humidity over 80 or 85%. That means a lot of humidity. So not a normal condition in most of European countries, just to let you know, because it's not, because somebody's thinking I could put a dehumidifier in my home and I will feel better. It depends on the kind of humidity you usually have. And I was suggesting that other factors are also very important, like pollution. Am I right? Bridget and Barbara, did you ever felt worse because of more pollution or more humidity?
Yes. When I used to cycle in London, I think that probably was not good. I didn't know I had bronchiectasis then, but it was really quite bad.
Yeah. So
air pollution, certainly, yes. I live in the countryside, but when I go into the city, I really notice it. The air pollution has a bad effect, and I'm coughing more frequently there. Yes. Not so much humidity. That doesn't seem to bother me much.
Mm-hmm. And somebody was also asking Sanjay about biologic therapies for asthma. What can you tell us?
So I think biologics in asthma has revolutionized this, but what's really exciting, to come back to bronchiectasis, is that there are, again, ongoing trials of the use of biologics in bronchiectasis. And I wonder if James wants to say a word or two about that. So this tells us, again, back to what I said during the talk, is that we need to identify that subgroup of patients with that specific type of inflammation that may benefit from a treatment that may traditionally not be applied to bronchiectasis, but may be applied to that subgroup of patients with bronchiectasis. And the good news is there's already clinical trials ongoing. Maybe James, you want to say something about that?
Yeah, that's right. So there's more than one clinical trial now going on of trialing some of these monoclonal antibodies. Barbara mentioned those during her talk. These are injections that help to target a particular type of the immune system. And some people with bronchiectasis have an inflammation in their bodies that is very similar to asthma, even if they don't have the label of asthma. And they can respond to these kinds of very targeted treatments. So it's again another point of hope that there may well be some of these treatments that can get to patients faster because they're being repurposed, they're being taken from asthma and then applied to bronchiectasis.
So, as you just mentioned, the immune system in bronchiectasis, there are people asking about associated diseases in bronchiectasis, like inflammatory bowel diseases, or rheumatoid arthritis, or psoriasis, and even thyroid problems. So, what do we know about these autoimmune, autoinflammatory diseases in bronchiectasis?
Yeah, so around 10% of people who have rheumatoid arthritis will develop bronchiectasis. It's a similar proportion of people who've got inflammatory bowel disease will develop bronchiectasis. These are conditions where the immune system mistakes the body for a foreign invader, and the immune system attacks part of the body. And the gut in particular is very closely linked to the lungs. And so sometimes the same antibodies that are fighting against the bowel in inflammatory bowel disease will attack the lungs. And likewise, the joints in rheumatoid arthritis, you'll get the same problems attacking the lungs. So they're very closely linked, and it's an important cause of bronchiectasis, and the two conditions can exacerbate each other, and so they both have to be managed very carefully.
Thank you very much for the answer. So thanks, Sanjay, James, Barbara, Bridget. Do we have the time for a break, right?
Yes, we do. Yes. And just one final point about research. A number of people have asked how they can participate, and we've put a couple of links to pages in the answered Q&A, so you can have a look there and see. But we'll also, I think, try and put something in follow-up material to help you with that. So thank you to everyone for participating in this session, and to all of the people who've been doing sterling work answering the questions and in the Q&A. And we're now going to have a break for 40 minutes. During the break, we're going to spotlight Rose Matheson, our visual monitor, who's drawing pictorial summaries of all the talks. And Claire, if you could spotlight Rose, that would be great. And then we will go on our break, and I hope you really enjoy the break and watching Rose. And remember to return at 1 o'clock CET, which is 12 o'clock GMT. And we'll see you then. And I think Rose will be available to be watched quite soon. Thanks very much. We'll see you at 1 o'clock CET.
Thank you all.
Okay, welcome back to the third session of today. I hope you all had a nice lunch break. For some of you, a bit of an early lunch break perhaps, or a late one, depends on where you are, of course. My name is Annette Postumus. I'm from the Netherlands. I'm a member of the patients group since the early days, actually. I feel very privileged to be in this group. It gives me a lot of knowledge about my own disease. I also appreciate the contact with other patients and experts very much. And at least, the opportunity to contribute to getting more knowledge about this disease. Well, that's a main part of being a member as well. I'd like to give the floor to James Jones, which doesn't really need an introduction anymore, as he was already with us in the session number 2. But please, James.
Thank you very much, Annette, and thank you everybody for making that such a fantastic interactive morning session. It's been really great to see all the activity in the chat. And do remember to put your questions in the Q&A. Anything you want to know about bronchiectasis, we've got our experts there on hand to answer your questions, and really pleased to answer those. We're going to kick off the next session, which is about other conditions that we have alongside bronchiectasis. And we've already had a lot of questions about this already during the first session. So I think this is clearly something that people want to know about. And so we're going to kick off this session with a poll, again using Mentimeter. And the question is, the question will come up in a moment. That's not the question. The question is what other conditions you have along with bronchiectasis if you're a patient with bronchiectasis. So if we just wait a moment, the poll, here we go. Thinking about your lung condition, have you been diagnosed with bronchiectasis only, bronchiectasis with another lung condition, or not sure? So the results are still coming in, but looking at these results, Annette, we've picked the right topic for this afternoon's session, because lots of people have other lung conditions like COPD and asthma as alongside their bronchiectasis. And of course, it's not just lung conditions. We heard earlier during the first session about rheumatological conditions, bowel conditions, and other conditions that people live with. So many people live with multiple conditions. So I think most people, it looks like most people have voted now. There's one or two still coming in, but shall we move on, Annette, to the first presentation? If you have additional lung conditions, can you tell us what they are? So you're going to now give us your conditions and we'll make a word cloud. So type them in short responses, please. And thank you so much for doing that. I think this is a really brilliant visual way of gathering this information. So asthma coming through very clearly there, COPD, NTM, PCD, allergies, severe asthma, allergic asthma, pneumonia, and lots of others. So thank you all for doing that. We just a couple more responses came through there. And we'll close this in 5, 4, 3, 2, 1. Give everyone a chance to get their answers in. So asthma's the big one. We've got COPD and many others there. So clearly the topic this afternoon is going to be an important one because we're going to talk about the overlap between those conditions. So over to you, Annette, to introduce the first talk.
Okay. Well, before we introduce you the speakers of this session, we will show you a video of two patients coping with multiple conditions. My name is Fran. I'm 80 years old. I live in London, and I have several lung conditions. Bronchiectasis is one of them.
Well, I am 80 years old. I have bronchiectasis, and I also have rheumatic arthritis.
I've also had NTM and various forms of pneumonia, also crypto-organized pneumonitis. So basically, I'm someone who lives with several lung conditions.
Now, because of the medication, I don't suffer pain, and I walk and I can do, but I can't do because every little thing I start doing, even in the kitchen, which is not really hard work, I, after some time, have to sit down and relax and catch my breath and continue. I can't do something for a long term.
My condition, my symptoms do change according to all kinds of factors, including the weather. Humidity plays an important part. And the first thing I do in the morning is to look at the weather report and the humidity and whether we're going to have high pressure or low pressure, because that's going to affect whether I'm going to go out or not go out.
And when I have to go upstairs, I have to sit down again and pant until I renew my breath. That if it's because of this or because of that, the whole thing is that I think they are interrelated in a way.
Having different lung conditions mean you need a lot of monitoring. You also need to remain well informed. We have, over the years, the decades, I should say, tried different therapies, different treatments. We have discussed the results, whether it worked, did not work. And where I stand today is the result of a very, very close partnership, collaboration, shared decision-making.
There's an expert in this and the expert in that. There's no connection between them. The family doctor is in between, but he also is, I can't say, very involved in talking and changing ideas with the experts.
This complexity is difficult to navigate both for the healthcare professional, the specialist, and for the patient, because it means trying different treatments. In my case, we tried for a number of years, actually, different types of inhalers, which really didn't make any difference.
Would say you were a busy person, doing whatever you've wanted, and suddenly you can't. I can't go for a walk, although I think of walking a long time. I just can't do it anymore. I decided to go to talk to somebody in our medical system. I'm a social worker, and now I'm in if I can say so, series of talks with somebody as to how to cope. We don't talk actually about my condition, my medical condition, because I went and decided to go to her because I had problems with actually coping with the whole condition surrounding it. With my husband, who has medical problems, and we actually have to cope with the fact that things do deteriorate, and that's what's hard. And so she, in a way, she actually my little kind of tried to say that first you have to pay attention to yourself, because if you don't pay attention to yourself, you can't help anybody else.
I think what's important is to avoid denying anything, which is why sometimes I'm concerned about advice given to patients to be positive. It's easy to say, but it's not easy to do. So instead of that, face reality. Yes, it's going to be hard, but there's nothing you can do about it. You can't change the situation. That's your reality. Yes, it's bad at times. It's very bad. But then, 5 minutes later, 1 hour later, the next day, you feel different about it, and keep yourself busy.
No, I think life is fair. I think it's what you make of it. And I think that if we find something that interests us and that we are able to do, that is, to write a book, or to be interested in whatever other thing, or if you can volunteer to go to help other people in your condition or less privileged than you are, then that's a fantastic way to cope. It helps you cope with yourself and others.
Well, for someone who has just been diagnosed, I would recommend to them that they ask the healthcare professional what he or she thinks are the best resources, the best sources of information in relation to specific disease. That would be a good start, so that the patient can start reading, can start thinking about it, because that will help the patient to ask better questions at the next encounter, the next consultation.
A big thank you to our patients for giving their perspectives on the overlap between different conditions. And I think we heard some important, both positives and negatives there, and some advice for the future. I'm delighted now to introduce our first lecture of this session. And it's my friend and colleague from Barcelona, Eva Polverino, who's been a long-time researcher in this field, with a particular interest in the overlap between different conditions, who's going to talk to us about bronchiectasis and airways diseases. Eva, over to you.
Thank you, James, and thanks for the introduction with these nice videos. So I'll start sharing my screen to show you my slides. Give me just 1 second. Can you see them? Can you see the slide?
Yes.
So, what I'm going to touch today is the association of bronchiectasis with other airways diseases, and you will see I will talk basically about asthma and COPD. That are the most common ones, so the ones that are more frequent in the population with bronchiectasis. So I'll start just telling very simple things. Give me a second, because I'm struggling. I'm trying to close the Q&A, otherwise I cannot see very well my screen. So the first thing is to know is just remind you what usual symptoms of bronchiectasis are, like cough and sputum, right? But also fatigue, dyspnea, so breathlessness, sometimes hemoptysis, frequent exacerbations, and so on. This is the classical symptoms most of you possibly feel. Now I'll tell you, for example, what COPD symptoms could be. they also have cough and sputum production. More typically, they suffer dyspnea or breathlessness. Usually they smoke. They used to have frequent exacerbations, fatigue, and they usually tell you I smoked or I had some other kind of exposure to toxic inhaled products. Then let's talk about asthma symptoms. Again, cough, dyspnea, wheezing, that is more typical of asthma, fatigue, frequent exacerbation, sputum production, some of them. Hemoptysis is possibly less frequent. So more or less the same. Am I right? Oh, my computer is running too fast. So if we look at these three conditions, bronchiectasis, where, for example, I would say hemoptysis is the most typical one, apart from cough and expectoration. It looks very similar in terms of symptoms to asthma, where we also have sputum, cough, dyspnea, and so on. Maybe in asthma, what we found more typical is wheezing, but we know that wheezing can be everywhere, also in other patients. Allergies are more typical than asthma. And if you look at COPD, forget me. So COPD means chronic obstructive pulmonary diseases and includes chronic bronchitis and emphysema. So in COPD, what we find as a differential element would be smoking or other kind of exposures. But you see this list of symptoms in the middle can represent in all of the three: cough, sputum, dyspnea, fatigue, frequent exacerbation. So it's challenging, is it? Because they are very similar. So let's try to understand a little bit more how these diseases behave, where they come from. So this is the typical image from a famous movie of a child with asthma taking an inhaler. So the typical representation we have of asthma. And I selected this picture because it's a child, and usually asthma can start very early in life. So it can be present for a very long time. And this figure represents how bronchi look like, right? So you have three elements, a lot of mucus, excess mucus. You see the bronchus on the right, that is compared to the normal one on the left, okay? So you have a lot of mucus. You have a swollen lining, right? Muscle tightens, so bronchi get close, they close in response to a number of stimuli that could be allergens, for example, or pollution or other things. So it becomes more difficult for air to go through the bronchi, right? So this is the representation. What are the usual symptoms? Shortness of breath, chest pain, whistling with sound, coughing attacks. And the triggers could be allergy, as said before. It could be the usual flu or cold, smoking, but also emotions. Many people say, when I start laughing, I used to have a cough, I have to stop, I need to breathe more deeply. So these are the typical aspects of asthma. What about COPD? You see the picture. Clint Eastwood, unfortunately, was smoking in most of his movies, right? Because at that time it was considered normal. The strong men had to smoke. We know it is not like that today. But unfortunately, this is going to represent that smoking is a key element in COPD disease. So another picture to show you what's going on in the bronchi of people with COPD. So you have chronic bronchitis with a lot of inflammation in airway wall. And also you can have a component of emphysema that is represented here, where you see like, it looks like grapefruit, right? You have a bunch of small alveoli where air diffusion takes place. So where we take oxygen and remove CO2, that is what we need to eliminate from the lungs, right? If these alveoli become bigger, this lung is not working properly. So gas exchange is not working well, and this causes fatigue and difficulty to breathe. So in COPD, the different causes usually represented are smoking, but also pollution. In few cases, we also know a genetic disease could cause a deficit in alpha-1 antitrypsin, that is a specific enzyme that usually defends our lung parenchyma from external damage, from smoking, for example. So there is a rare condition where this enzyme is missing. And it is clear that increasing age makes COPD worse. Usually it's a long exposure to smoking that causes COPD, and with aging, symptoms become worse. So we have chest tightness, cough and sputum, chronic dyspnea, wheezing sometimes, and also weight loss in the last part after many ages. So on the left, you see the typical representation of somebody with COPD after many, many years. The typical patient in our clinics that needs oxygen supplement, as I said, because gas exchange is not working very well. So difficult to breathe includes use of accessory muscles to breathe properly. So many times the heart is also suffering because of lung insufficiency. So there is also what we call cor pulmonale that is and heart involved in this. So they are different. We know what bronchiectasis are. I think so. You have seen what asthma looks like, the same for COPD. Why should we look for airways comorbidities in bronchiectasis? First of all, I will tell you that they are frequent, and I'll show you why. And then the outcome is not the same. It's not the same having one or two diseases together. And more than that, +1 + 1 is not always 2. This is not maths. This is, I'll show you that putting together two diseases cannot simply be a sum of the two. It's even worse. And the management, as you can imagine, cannot be the same. So this is the usual representation of potential causes, of bronchiectasis. So the final outcome is bronchiectasis. What can cause bronchiectasis? Infections, maybe in the childhood. Airway diseases, you see here COPD, asthma, and ABPA, that means aspergillosis. We've talked about it. Some inflammatory diseases, autoimmune and autoinflammatory diseases. Rheumatoid arthritis is one of those. Inflammatory bowel disease as well. Immunodeficiencies, if the immune system is not working properly for any reason, we cannot get rid of infections, and the persistent infections can cause development of bronchiectasis. And then more rare diseases like primary ciliary dyskinesia, where the cilia are not moving, and other rare diseases are also mentioned. But what do we know more recently? We have more data from the EMBAC database. Sorry. In a second. Okay, so what do we know about the presence of asthma in our patients with bronchiectasis? What we did was to look at our database. More than 16,000 patients, it's a lot of patients, and the investigators involved in collecting this data say that 31% of all patients could have asthma as a cause of bronchiectasis or as a comorbidity altogether. But you see that the percentage is quite high, 31%. What did we find? What do we find in these patients with associated, or we assume associated asthma? In general, they're younger. We find more females, usually non-smoker. We find more allergy, polyps, and rhinosinusitis. But likely, they show less severe bronchiectasis. You can see their quality of life, unfortunately, is lower. They're less severe, but their quality of life seems to be worse than for bronchiectasis with other conditions. They also have more exacerbations. If you see on the bottom right, the red column is representing the number of patients with 3 or more exacerbations. And the red column from the asthma group on the left is higher than the other one. So it seems they have more exacerbations, but usually they are milder exacerbation. The bad thing of this study that we identified very few patients only investigated for asthma. If you want to study asthma, you have to do specific tests. And unfortunately, very few patients were investigated, but underwent these kind of specific tests. But the good thing, we could identify the patients with asthma or reported to have asthma. In case of using inhaled corticosteroid, we're receiving some benefit in terms of hospitalization. So they were doing better with inhaled corticosteroids when asthma was described. What do we know about COPD? That is, after asthma, the second most common respiratory chronic disease in the world. So the first thing we did last year was try to define, because COPD is usually related to smoking, and it is usually related to the presence of bronchial obstruction. What is bronchial obstruction? Is the presence of specific numbers at a spirometry. That is the test we always ask our patient to repeat routinely to see how their lung function is. So the presence of these two elements is usually defining COPD. But what about the presence of the two? So at the end of this survey, international survey, we decided that the good definition for having COPD and asthma and bronchiectasis together was the association of course, we need bronchiectasis on a CT scan, so radiology is required. Of course, we need symptoms, cough, sputum, dyspnea, and so on. We need bronchial obstruction, that is this number FEV1 over FEVC, that is the spirometry parameter, and finally, the presence of smoking or any other exposure. So having defined COPD, that in this case was relatively simple, then we went to look for this definition for the presence of COPD more in general in our database, EMBAC database. Again, it was quite surprising that over the same amount of people, almost 17,000 patients, 20 to 25% had COPD. Again, it could be reported as the cause of bronchiectasis. It could be reported as an associated condition. And what you find here is 20 to 25, because the difference depends on what kind of definition you use. Many doctors define COPD as like clinical report without looking at specific data. Yeah, so they think they had COPD. It was not a very precise definition. Anyway, independently of the definition, what we found in these patients also having COPD is they were older, usually male, and they used more medication, more oxygen, more mechanical ventilation. In general, they were more severe and more worse outcome. But the great point, the big point here, and I would say the weak point, is the fact that we found a lot of misdiagnosis. Imagine that over 30% of all patients that were reported to have COPD had never smoked. So it's a minimal requirement to define COPD. So it seemed that doctors were tended to define COPD those patients that looked more severe, because we know that this association is not good. And in general, we could find that COPD patients with COPD and bronchiectasis, again, had worse quality of life, more exacerbations, more hospitalizations, right? So it's like we can depict two profiles, right? Asthma and COPD. So these images were chosen, yeah, they're funny, I know, but mostly because you find more females in the asthma group, more males in the COPD group, more older people in the COPD, smoking people, and a lot of inhalers in the asthma one. Yeah, it's a simple way, but there are more differences than that. If you go to more detailed elements, we know that in the lungs of people with asthma, there are a lot of eosinophils. Eosinophils, one of the cells that play an important role in determining the kind of inflammation they have. While in the COPD profile, we find a lot of neutrophils, a different kind of cell that is determining a different type of inflammation. So sometimes it's not very clear, because there are some patients that do have both eosinophils and neutrophils in the sputum, or they can change one state to another. But in general terms, these two profiles are useful to understand what we could do. And I told you at the beginning, sometimes the whole is more than the sum of its parts. So look at these guys. Maybe between 70 and 80s, the typical patients we can see in our clinic. Individually, they don't say very much, but if they are together on a stage, they play a great music independently of their age. So this is the same. Unfortunately, when we do have two different diseases together in the lungs, the result can be much bigger than having the two of them separately. Now, I'll leave you with this simple figure. It's simple but complex at the same time. So we have different conditions. They can be together in a quite important proportion of our patients. But what do we do with the drugs? Okay, if we go, for example, for bronchodilators, that can be useful in bronchiectasis when we have dyspnea or before physiotherapy, for example. The same with asthma. And in COPD, they are commonly used. It's like the basic treatment for that. What about steroids? They are useful in those patients with eosinophilia. It seems like we don't have clinical trial, but it's very, very likely it should be like that. It is like a key treatment for people with asthma. And in COPD, sometimes, few times. What about inhaled antibiotics? It's very common, right? In bronchiectasis, when we have a chronic infection that is not under control, but they cannot be used in presence of asthma, or it's very difficult to use them because the risk of bronchospasm is very high. And in COPD, they can be used, but with attention, and the evidence is becoming more and more relevant. It's not as big as for bronchiectasis or CF or cystic fibrosis, for example. Macrolides seem to be useful in the three conditions because of their antibiotic and anti-inflammatory properties. But still, we cannot forget the potential side effects and the risks related, for example, to induce resistant non-tuberculous mycobacteria infections. Physiotherapy is very good everywhere, but in presence of wheezing, bronchospasm, or asthma, we need to use specific maneuvers to make sure there is no bronchospasm induced. Those low expiration maneuvers are necessary in presence of asthma. And for mucoactive, they're also very good. But there are few patients with allergy or with asthma phenotype where, for example, acetylcysteine cannot be used because it could increase the risk of bronchospasm. So the differentiation and the definition of these groups with different diseases together is important. We talked about phenotypes. It's important because there are clinical differences to treat. And there are differences in terms of outcomes because we need a personalized treatment. Different patients could have different tolerance to the same drug, or they could show different contraindications, or they could reimburse in one country for a drug, but not in another country. And what is more important to you as audience today is that we need patient empowerment. I think it's very important for you to know if you belong to a specific group, which group, what the disease looks like, what's the definition. You need to understand your disease to manage it properly today, tomorrow, and at long term. And maybe because this makes a difference if you want to get included in a trial. Many of you wanted to be more involved in research. So this is very important. Now also having access to a service that is specific, for example, to asthma, COPD, apart from your bronchiectasis could be very important. As a conclusion, one size doesn't fit all. We need personalized treatment. And I think that's all for me. I want to thank Letizia because the best slide on Rolling Stones was not made by me, but young people is usually better with this kind of images. Thank you very much. And I stop sharing.
Thank you very much, Eva. Very interesting talk. I now like to introduce our next speaker, Fiona Musgrove. Fiona Musgrove in 2012. She works in a large practice in Aberdeen, Scotland, and she developed a special interest in respiratory medicine in 2018. And I have to read this out, this is so much. She completed a master project focused on the microbiology of bronchiectasis exacerbation. So that's a sentence. Please, Fiona.
Thank you very much, Annette, for that very kind introduction. I'm just going to share my slides, which hopefully you can see. So thanks very much for asking me to come and talk to you about complications and coexisting problems. It's a tremendous privilege and a pleasure, and not without challenge, I have to say, because there are lots of, as we've seen from the earlier sessions, lots of potential complications and coexisting problems. My disclosures aren't particularly relevant, but they are there for you anyway. When I was thinking about what to talk about, I thought a great deal about what I would cover and then settled on going for a couple of the common conditions that occur with bronchiectasis. And I'm going to talk a little bit about each of those and then give some general advice and some proactive management tips. I'm going to avoid as much as possible talking about specific medications because that will probably unnecessarily complicate things, but I am happy to take questions really about anything. So as Annette said, I always think it's important just to outline why I'm able to talk to you about this. So I've been a GP for about 11 years now, and I developed an interest a number of years ago with a particular focus on bronchiectasis. And I work as part of a community respiratory team. I also work in an outpatient clinic in the hospital looking after patients with difficult to treat and severe asthma. And I also work in a primary care setting. So I've got some general and specific experience, which hopefully will help me to deliver this talk to you. So I've used this slide before and I make no apologies for using it again. I think it's always important to start any talk about people and health with a bit of understanding about what we mean. So in my experience, when we talk about physical health and mental health, we talk about them in this way. And this diagram represents that we treat them separately often. And that's certainly been my experience a lot of the time in healthcare. But actually, when you think about it, it's all just person health at the end of the day. So there's an overlap, and we're all people, and we all experience physical and mental health. And those things overlap. So physical health problems will often give you mental health symptoms and the other way around. And what that means is it's important for us as clinicians and researchers, but also for patients to be aware that there are a whole range of areas that we're trying to deliver care across. So it's really about the whole person. And I think if we can keep that in mind when we're delivering care and when we're experiencing chronic health conditions, I think that's really important. So we've got to kind of look after all these bits of ourselves to varying degrees. So this spinning top represents the fact that I like to think of any chronic condition as you having to spin your axis, your life around an axis that you haven't chosen. So you can choose to an extent your job, your hobbies, but you don't choose to have a chronic illness. And when you have one, whether you choose to do things to help or not, you will still have to do some things, live your life around the axis of that thing. And I have stolen this analogy from the 4-Pillar Plan, which is an excellent book that I would highly recommend. I like to think of having a toolbox. So what things are in my toolbox to help me deal with the things that I have to deal with? And the 4-Pillar Plan looks at sleep, eat, move, and relax. So I'll come back to this again, but those are the 4 big groups that things fall into that we can generally do across a range of health problems that can help us. It's also really important just to lay a bit of background in general, setting the scene for talking about any condition. So generally in health conditions, there will be an interaction between your individual genetics and things in your environment and your lifestyle that leads to that condition. So that will be relevant as I'm going on to talk about these things. So you don't pick your genetics. You can manipulate your environment and your lifestyle to an extent, but it's important just to be aware of that. So first of all, I'm going to talk about gastroesophageal reflux disease, which is affectionately known as GORD or just reflux or indigestion. Occasionally you hear it referred to as dyspepsia. But essentially, this diagram is showing you that what happens normally is that when you eat, things go down your gullet or your esophagus into your stomach and a little valve closes to keep everything in there. If you've got reflux, the acid contents of the stomach reflux come back into the bottom part of your gullet, and it can cause a range of symptoms that are listed here on the slide for you. And it can cause really quite intense, unpleasant abdominal pain or a burning sensation in the lower part of the chest. Sometimes patients just feel persistently sort of a bit sick or a horrible taste in their mouth or just slightly queasy. So any of these things may be a symptom of reflux disease. There are things in your background, so particularly family history. Some of my patients have a strong family history of reflux disease, and that just means that they're more likely to get reflux even if they avoid all the triggers. I have included a photo of a delicacy, an unfortunate delicacy in the northeast of Scotland, which is a Mars bar chocolate bar, battered and deep fried. So that will almost certainly give you reflux disease, and it's not a delicacy I would suggest you attempt if you're ever up in this part of the world. But foods that are high in fat, anything that we probably want to eat. So fatty things which taste nice, alcohol, so a glass of wine, coffee and chocolate can all be triggers. If you're very stressed, I will often see patients with stress-induced symptoms of reflux, and smoking. Some medications can also increase your risk of suffering from reflux. So generally what we would talk to patients about is avoiding the things that seem to trigger it, or at least being aware of what does trigger it. It might be that you still choose to have a glass of wine, for example, but you know that you might expect some reflux after that. Raising the head of the bed can be quite helpful, but you do actually have to physically raise the head of your bed. So propping yourself up with pillows doesn't tend to work particularly well. It can actually make it worse. So it's putting bricks or something under the actual head of the bed to tilt yourself up slightly. Smaller meals and eating an earlier evening meal are often quite helpful. Reflux symptoms often are worse at night. And I said I wasn't going to talk about medication, but you can use antacid medication. So usually some liquid medication that just actually sits on top of everything in your stomach and physically helps prevent that reflux can be quite useful. If I'm talking about reflux, it would be very remiss of me not to mention that there are sometimes things in reflux that make us more concerned. So if you see somebody with reflux, or if I see somebody with reflux, I will investigate them often a little bit, depending on specifically what their symptoms are, and give them some treatment. If they're not responding to that treatment, particularly if they're over the age of about 55, that would make me think about whether we want to sort of look into things a bit further. If there's vomiting, again, particularly if that's not responding to treatment, losing weight is often not a particularly good sign, and any back pain, particularly if it's higher up in your back, so the kind of back of your chest, if you like. And these are things you'd want to see your primary care provider about, because we probably want to think about doing some more tests to try and understand what's going on and make sure it's nothing to be unduly concerned about. So moving on a little bit to high blood pressure. So high blood pressure is really common in general, and it is one of the main comorbidities that we see in patients with bronchiectasis. It tends to be something that doesn't cause too much in the way of symptoms unless your blood pressure is really high, very, very high, which we don't see terribly often, fortunately. And that would sometimes cause a bit of headache and dizzy feelings, but generally speaking, there are no symptoms. And we pick up a high blood pressure as part of a routine checkup, or it might be that you're in because you're having a flare-up or a chest infection, and we happen to check your blood pressure. So there are two numbers. There's the systolic, which is the top number. So that's the pressure in your heart when it is pumping, and diastolic, which is the bottom number, which is the pressure in your heart when it's relaxed. And a blood pressure of above 140/90 on average would be classed as high blood pressure. Getting an average blood pressure reading is a little bit tricky, because coming into the clinic isn't really an average situation. And for most of us going to visit someone in that kind of setting, we might have a slightly higher blood pressure. So if your readings are normal when you're in clinic, we're usually happy with that. But if they're higher, what we then tend to do is arrange for you to have some home monitoring, and we work out an average over usually a week. And we'll often add a little bit on. So if you're doing home readings, when we work out the average number from them, we add 5 onto the top number and 5 onto the bottom number. And there are stages of high blood pressure depending on what the specific numbers are, and they help us decide on what sort of treatments we want to give. So it's a little bit complicated, and it can take a while to diagnose. Many of your risks for high blood pressure are things over which you won't have a great degree of control. So as you get older, if you've got a family history, and again, many people have a strong family history of high blood pressure. Certain ethnicities have a high risk of high blood pressure. And we know that there's a an association between living in a less well-off area and a general increase in your kind of heart risk, and your and high blood pressure sits along with that. But things that might have an impact on it that are sort of modifiable would be smoking, alcohol, salt in your diet, and low physical activity. Increasing physical activity will generally help with blood pressure to an extent, even if it doesn't cause weight loss. So it's not the case that you need to exercise to lose weight. Just moving will be helpful for your blood pressure. Weight loss, if you are having problems with your weight, can be very helpful. Reducing salt in the diet is often a big one that I will speak to patients about. So you can do that by reducing how much salt you add to food, either when you're cooking or once you're at the table, but also checking labels, although it's a bit time consuming, can be helpful because many foods will have a lot of salt added to them. If you're chronically under stress, you can run a higher blood pressure because your stress hormones will move your blood pressure up a little bit. And so things that help you personally as an individual to reduce your stress are likely to be beneficial. Sleeping is really important, and that's across a range of health problems, but for blood pressure particularly. So a good quality of sleep and number of hours of sleep are really important. And if you're somebody who doesn't sleep well, then thinking about starting to look at that might be useful. Reducing alcohol and caffeine, particularly before you go to sleep, are generally a good idea. Alcohol often shortens the time it takes you to get to sleep, but will impact on your sleep quality. So often people who don't sleep particularly well will use alcohol to help them get to sleep, but it doesn't always work as well as you might expect. So you might get to sleep quickly, but then actually your sleep quality might not be great. And caffeine hangs around in your system for a long time after that cup of coffee. So generally, I would say avoiding caffeine in the afternoon is a good idea. It can hang around for up to 7 hours, and even decaffeinated coffee, tea, etc. will have some caffeine in it. So it's just worth bearing that in mind. In terms of exercise, I should also put in here exercise/activity. So doing what you can is always going to be helpful. Making that part of your routine, again, is really useful because generally speaking, routine can either be your servant or your master. So if you have things that you know are important for your health, then generally making them a part of your routine tends to make them more likely to happen. I'll come back and talk about SMART goals again a little bit at the end. But in exercise and fitness nowadays, there are kind of a couple of different areas that we're hearing are important. So we all know that doing something that raises your heart rate and increases your work of breathing and gets you a little bit out of breath is generally a good thing to do. But also strength work is important. So we know that often across a range of chronic health problems, and particularly in respiratory health problems, you can lose muscle mass. And that is generally not a good thing. So working with a little bit of weights, whether that's dumbbell weights or your own body weight or in the gym, can be really beneficial. So I'm going to move on to bone health now. Osteoporosis, I think, has come up in the chat a little bit. So osteoporosis is a thinning of your bones. And bone is a really interesting tissue because it is a living tissue. And there's a continuous cycle of breakdown and of build-up. Your bones are as thick as they're ever going to be from about your mid-20s, and then your bones get thinner over time from then. And as women, particularly after the menopause, your bone mass drops off more sharply. So if you have thin bones, we call that osteopenia. And if you've got more severe thinning of the bones below a certain threshold, then that's osteoporosis. And the problem with osteoporosis is that it places you at risk of something called fragility fractures. A fragility fracture is simply a break of a bone that's caused by a fall or some sort of incident from your own height or lower. So if you think of tripping and popping your hand out to break your fall, we wouldn't normally expect somebody to break their wrist doing that, but you might do if you have osteoporosis. And the three big areas that we see breaks of the bones in are the wrist, as described, the hip, and in the bones of the spine and the vertebrae. So as I said, often the first presenting symptom of osteoporosis is a fragility fracture. And again, wrist, hip, or spine are the common ones. If you're having breaks of the bones in the spine, but you're not aware of them, you may end up with a stooped posture because they tend to fracture in a wedge shape. They tend to break in a wedge shape, and that sort of tips you, and you get this kind of humped appearance. Occasionally, if you have an acute break of a bone in your back, you can get very severe back pain, and that might be a way that we know that you have osteoporosis. If you develop a stooping of your posture, you will often lose height as well, and that's again part of those bones in the back and dropping height. So these are all kind of fairly familiar risk factors in terms of the other things I've talked about, but women, again, after the menopause are at increased risk of osteoporosis. And I guess that the main one here would be oral steroid use, just to draw your attention to. So if you're needing regular oral steroids, then bone mass is something we try and look out for. And if I have patients, for example, in the asthma clinic who are frequently having flare-ups and needing prednisolone or oral steroid, if they've had a number of courses, I will often request a bone mass assessment so that we can make sure their bones are okay. Generally, having a healthy lifestyle, so weight-bearing exercise is really important because that will stimulate bone growth. So regular weight-bearing exercise. If you can, and walking is absolutely ideal for this, but outdoors also, because that big yellow thing in the sky that we occasionally see here in the Northeast, the sun is how you produce a lot of your vitamin D. It's worth thinking about supplementation. So again, where I live, there isn't enough of the correct wavelength of sunlight in many months of the year to actually allow you to produce vitamin D in your skin. So many of us will take a vitamin D supplement, and that's not a bad idea. So drawing towards a close, the last sort of thing I'm going to talk about is mental health. So I've stolen this slide, but I really like the image. I think it says everything it needs to say. So mental health is something that we all have or don't have, and it's on a continuum. So we feel differently day to day, minute to minute, month to month, depending on what's happening in our lives, in the world, how our health problems are. So we're really impacted by what goes on around about us. It isn't an absolute, it's very changeable, and it's not, I really like the comment in the video about, feeling positive all the time and how that's not really helpful. So it isn't just sort of bashing on and feeling positive all the time. It's not sort of pretending to feel okay when you don't feel okay. And it's not something you can just change at the drop of a hat or at the snap of your fingers. So I really like this image as a good summary of what mental health is and isn't. If mental health problems are becoming more severe, so rather than this kind of fluctuation where things change a bit, if you feel that actually, when was the last time I felt like I was happy, or when was the last time I wasn't worrying all the time about something, when it's become really kind of all-consuming, then we're thinking about depression and anxiety and perhaps being a problem. Winston Churchill famously suffered from depression, and he seemingly referred to it as his black dogs. So this book, I Had a Black Dog, and there is a partner to it called Living with a Black Dog, written by Matthew Johnston and his wife. And he suffered from depression over a number of years and has written really a beautiful picture book with some narrative going through it, which I would highly recommend to anyone that has suffered or is trying to explain it to someone who hasn't suffered. They're really very simple and very powerful. Again, this is another really wonderful book, Manage Your Mind, which I often refer to in talks. So it talks about anxiety and depression being the twin enemies of good mood. So when you have anxiety or depression or both at the same time, I like to think of that as a filtering of perception of yourself and of the world. So it's like a filter being popped onto the front of a camera lens, and that affects all of the images. So everything that you see will usually either become negative or worrisome or a combination of those. Sometimes there are reasons why it's happened, but often there aren't. And it just leads to this constant sort of overshadowing of worry or negativity. And it will affect your whole person. People will often find that they're not sleeping very well, that they're not eating, they don't feel like much of an appetite, they can't really get focused or doing anything because they're just not able to concentrate because the brain's sort of going like a hamster wheel, and often just not being quite yourself. People maybe saying, "Oh, is everything okay?" or maybe a bit short-tempered with me. So that's how you might know that you're slipping into those. And generally, if that's happening, seeking some help from somebody involved in your care to look at the options around what sort of things might be helpful. But I think actually, again, what was mentioned in the video is very important. Sometimes talking about it with someone and looking for ways that you can start to sort of not pull yourself out of it, because that's the wrong description, but ways that you can start to refocus things, really important. So I'm going to come back to this slightly stolen image again, but the Manage Your Mind book kind of talks around these things. So strategies that you can use from across these 4 areas of life to try and help improve things. And the book really is, the 4-pillar plan book is really simple and easy to use. So again, I would highly, highly recommend that. So I think by some sort of magic, my poll question is going to appear, which is if you've ever made the statement that you're going to exercise more. And you can no comment if you wish. Okay, so far, most people have. Okay. So a fairly overwhelming majority saying yes. That's fine. We'll just give it a couple more seconds. I think we've probably got the main message from that one. So if I can ask for us to close that and just, that would be wonderful. Oh, where are my slides?
Sorry, Fiona, you'll need to share your slides
again. Okay, it's fine, I can do that. Oh, there we go, that's it. So I said I would just spend a little bit of time talking about SMART goals. And what SMART goals are is how you move from I'm going to do X thing more, or I'm going to do a bit of mindfulness, or I'm going to try and sleep better, into actually making that happen, because it's quite tricky. But SMART stands for specific, measurable, achievable, realistic, and time-bound. And I tend to think about using a small trigger in your habits, just a really straightforward thing that you can do to lead you into that. But I also think it's really important to start small and to take the small wins. So it's very easy to say, I'm going to exercise more and I'm going to go out 4 times a week, regardless of the weather, and to have really big ideas, because we all want to achieve things. But actually, if you start smaller, you're probably more guaranteed of success, and you're certainly more likely to feel empowered by the small changes that you see. So SMART exercise goals, for example, might look like this, but it's a very specific, small amount of time, number of times a week for the next however long, and then you're going to specify the days and the times, and you're going to use some sort of trigger. And it might be putting your trainers on, or it might be setting an alarm, but something that's nice and straightforward, and you need to reassess that regularly to allow yourself to see the positive benefits, okay? And this can be used for anything, and I have used it myself for exercise and other things. It is very useful because you're holding yourself to account. You can write this down. It's important that you do write it down. I will do this on these days, and then you can see your own progress. And as I say, you can use it really for anything. So just drawing us to a close, I think my take-home messages are probably that it's about whole self, and looking after your whole self, whatever that means to you, is a really wise investment. Managing chronic illness, whatever that is really challenging. It's time consuming, it's frustrating. You did not choose it, but you are having to devote some of your time to it, and that's not easy. But small things can make a really big difference. I think being aware of your family history, and that there are things in your genetics that you didn't pick, you can't do anything about any of those, but you can start from where you are and look at where you might want to make changes and move towards those in a really realistic fashion. And I'm just going to finish by saying that I think that the 4 really big things are to eat, sleep, move, and relax. And this is actually a picture of my cat, who is the most relaxed being in the entire planet. I'm really happy to take any questions. I'm aware there were things that that people were keen for me to cover that I haven't quite managed to work in there. So I'm happy to answer any questions that I haven't touched on there. Thank you very much for your time.
That was wonderful, Fiona. Thank you very much for taking us through those 4 key components of a healthy life. And thank you to both of our speakers for being perfectly on time. So we've got 20 minutes for questions. Will I kick off with the first question to Eva? There's a few questions in the chat about misdiagnosis and particularly misdiagnosis of asthma. Some people asking, they think maybe I've got asthma, maybe I haven't got asthma. What's the relationship between bronchiectasis and Airways disease and that sort of misdiagnosis, and how do patients resolve that?
So misdiagnosis is a huge problem, something that could be confusing for you as patients, but is confusing even for us as doctors. And the papers I showed you confirm it, because there were a lot of mistakes done. And possibly it is because of the overload we used to have. It is possibly because of the fact there is a lot of information regarding asthma and COPD. And it is so much that sometimes even confusing, because influences you as a doctor in a bad way. So everything that is wheezing could become asthma, and everything that is dyspnea could become COPD, because that's what we know from the very beginning. But we have the tools to investigate these conditions. The most important thing is to have a good conversation with your doctor. We are starting to work on these, trying to define what is asthma in bronchiectasis, what's COPD in bronchiectasis, what are the effects of these combinations. Not easy, right? But consider, and not something else, that bronchiectasis itself is a chronic disease with chronic inflammation that could show up with a number of different functional disorders. So it could be you have like bronchial obstruction, it could be you have restrictive pattern, it could have a mixture of the two things, you could have simple normal lung function. Bronchiectasis is not well represented from spirometry, because there is a variety of representation. So you cannot trust spirometry on only spirometry to convince yourself you have asthma or COPD or none of them, so on. It's complex. So the important thing, we as a doctor have to do more to investigate these conditions. Consider these publications are from last month. And there is very little information about how to diagnose asthma in bronchiectasis. There is a lot about asthma, about COPD. We have a bit more on the combination of COPD. So it's confusing, it's not easy, but there are a number. The most important thing is to have a good relationship with your doctor, to explain to them very well your history, what started, what kind of symptoms you started to happen when, what tests you can get access to. So an important thing is to get a good communication, and everything will move forward together, right? So it's confusing and there is a lot to be done, but misdiagnosis is very common. Overdiagnosis, underdiagnosis in both asthma and COPD.
So if it's confusing for us doctors, it must also be confusing for patients. Annette, would you like to answer? Would you like to ask a question?
Yes, it's a question for Fiona. How do we know if we have silent reflux with none of those symptoms? Does it make sense to still take precautions for GORD for those of us who have bronchiectasis?
That's a great question, and it's a bit of a tricky one. So, reflux has been labelled as a cause of lots of things, and I think as part of that, we've kind of talked about this thing called silent reflux. And the theory with silent reflux is that without any obvious symptoms, so not necessarily any pain or feeling sick or anything, that contents from the stomach come up and irritate particularly the back of the throat. I think unless you're having overt symptoms of reflux, I probably wouldn't do much about that, to be honest. So I wouldn't suggest that you preemptively treat reflux that isn't there. And it is a tricky area because the evidence around this and some of the guideline recommendations have changed a little bit recently. But if my patients don't have overt reflux, I don't tend to treat them unless they've got lots of throat pain that we can't find a cause for. Sometimes that is reflux, and we will then try treatment for that. But again, if the treatment doesn't work, then we wouldn't persevere with that. And we have to be a bit careful about which treatments we use. So sometimes we'll use acid-reducing medication, but we'll often also use antacids because sometimes those work a little bit better for that type of problem. So that's a difficult question, but a good one.
In very rare cases where there really is a big question about silent reflux, there are tests that you can do to look in the in secondary care to look for whether there really is reflux, but that's only done when the symptoms are really severe, and it's important to answer that question. Eva, I wonder if I can ask you a question. We've had multiple versions of this question in the Q&A about steroid inhalers. People asking, should I be on one? Are they safe if I've not got asthma? So what's the position with steroid inhalers in bronchiectasis?
Yeah, one of the figures I showed was representing a female with asthma and a man with COPD. I was showing that in one case, eosinophil is the most important cell. Neutrophil on the other side is the most important cell in COPD. So what is clear today that inhaled corticosteroids or steroids in general are useful when you have eosinophilic inflammation. So it's clear it's very useful in asthma. It is clear it is useful in those patients with any other chronic disease where eosinophils are playing a major role. So a subset of COPD patients may benefit from this intervention. Also patients with a lot of exacerbations in COPD, in the COPD world, also could benefit, right? But we also know that steroids could facilitate the growth, for example, of mycobacteria infection, the growth of mycobacteria, non-tuberculous mycobacteria, right? So it's always a careful and individualized decision, right? Steroids were used too much in the past. It was our mistake as doctors. Today, we know they are useful in some conditions, in some patients. So it depends on the kind of disease you have and the kind of inflammation you have and the kind of symptoms. Again, something that should be personalized today.
Great. Aneta?
Yes, I have a question. Let me see, where is it? Yeah. Is there an association between eczema and bronchiectasis? I would like to know the answer of this one as well.
Is that for me, I assume?
I think it's for you, but it's...
Yeah. So not specifically, as far as I'm aware. There is an association between eczema and asthma. Often it's part of a sort of allergic group of symptoms or allergic underlying cause. So if asthma is the cause of bronchiectasis, or if there's comorbid asthma, then yes. But not in general, as far as I'm aware. I can see Eva nodding, which is good. She concurs. So in some cases there may be. Good.
Yeah, can I ask you a question, Fiona? There's a couple in the Q&A from patients about bone health, about why people with bronchiectasis are more at risk of bone problems and what we can do. You covered some of it in your talk, but to sort of reinforce the messages about what people can do to look after their bones.
Yeah, so I suspect we don't know fully why people with bronchiectasis are more at risk. Probably part of it is to do with medications and steroid use, potentially, particularly in those patients who've got overlapping airways disease and need treatments for flare-ups. your biggest risk factors are, apart from those associated with your disease, are family history, particularly maternal history. So if your mum had a hip fracture, that's not great news. And actually, the most important thing is to be aware that bone health exists, and that we all get, much in the way that your lung function, even if you're healthy, gets worse as you age, so does your bone health. So your bones get less thick over time. And the protective things that you can do are not smoking, and regular weight-bearing exercise, and making sure you've got enough calcium and vitamin D in your diet, which most people will do. But if you're inside a lot and you're not exposed to sunlight, particularly between about sort of May and October, then you might run into problems with that. So getting your levels checked might be useful, but certainly supplementation. So I don't personally check a lot of vitamin D levels because of where I live, and the fact that actually for most people they're going to be frankly deficient or a little bit low.
If I can add something, unfortunately, lack of activity is something that is common in our patients because of their respiratory limitation. And this is clear one of the main factors that contributes to bone diseases. So I had a professor at university that was saying, if you want to keep your bones healthy, use them. And this is exactly what Fiona said many times. It is particularly important in respiratory conditions as well. So it's something that is common, but we need to have a look at it. Yeah.
It's true across the board. Exercise is good for every aspect of bronchiectasis, from clearing the mucus from the chest through to the breathlessness symptoms, and indeed bone and the comorbidities. Aneta?
Yes, I have a question for Eva. Is there specific research about IBD and bronchiectasis?
There is inflammatory bowel disease, I imagine, right? So there is little research, but there is, and I'll tell you why, because it's quite rare. So it's difficult to keep a good collection of data from patients. There is some research, and unfortunately what we have at the moment in the literature is mostly like case series reports. So doctors saying we've seen a lot of patients that have associated bronchiectasis that get worse after surgery to remove, for example, a section of the intestine that is particularly affected by inflammation. So it's like inflammation goes from the bowel to the lungs after a surgery. So unfortunately, it is more difficult than in other fields to do research, because of because of the numbers. It's obviously easier to do research when patients are more numerous than in other cases. But it seems to be not a systemic inflammation mediated mechanism, right? So, but there is some kind of inflammation. I don't know whether James is more aware about anything new on this topic.
Yeah, no, it's an area where there hasn't been an awful lot of research, but something that's important to remember is that when the human embryo is developing, the gut and the lung come from exactly the same place. Yeah. So the tissue that's in your gut is very similar to the tissue that's in your lung, and any inflammation that affects your gut can also affect your lung. And so that's why there's such a close link between having good gut health and having good lung health across the board, not just in inflammatory bowel disease.
Yeah. And there's another
eating a good diet is good for your lungs for that reason.
Yeah, and there's another connection point. It is the fact that, for example, patients with immunodeficiencies usually have both manifestations, respiratory infections and bronchiectasis and bowel diseases. So it's a quite common association in patients with immunodeficiencies as an underlying, like common variable immunodeficiency and other conditions. So you can see both manifestations as a kind of alarm sign to look after this.
Yes. Can I ask you a question, Eva, about NTM infection? Because you mentioned it in the context of steroids, and then there's a load of questions in the Q&A sort of from the patients. What is the frequency of NTM infection? Is this something that we should worry about if we've got bronchiectasis? So do you want to say a word about that as an associated condition?
Yeah, it depends on where you live, right? In the northern in Northern Europe, in the south of the US, or in some other regions of the world, the NTM are quite common or more common. But in the south of Europe, it's less common. It's less than 5% of all cases of bronchiectasis, while I would say it's about 10. What about UK, James? Do you achieve the 10% maybe there?
No, I think it would be less in the UK. In northern Scotland, I think NTM can't survive the cold temperatures or something because we don't see it as frequently.
Yeah. But if you look at, for example, the US registry, okay, our colleagues have a lot of NTM infections. It could be for environmental reasons or for some kind of bias in selecting patients. There are a number of potential reasons for that. In some regions of US, NTM are more frequent. This is clear. The same in some Asiatic countries, like in Japan, they're also more frequent. But in Europe, in general, it's less than 5%. It's a rare condition that still can be quite severe when present. But again, depends on what infection you have, since how long and how you're managing that infection. There's a variety of manifestation that you can see. So from very mild to very severe, the huge heterogeneity can be observed.
Yep. Annetta?
Yes, we already spoke about a bit about any particular sports which are really good for bronchiectasis. There was a question about, for example, swimming.
So that is another great question. I think the most important thing is that it's something that you will do, that you can do, that you like doing, and that you will do. So I personally, I walk and I run, and the reason that I run a lot is because I like to run. If I didn't like it, I wouldn't do it very often. So there isn't anything specific, but whatever you can do, you should do, and you should do it regularly. So, and it might be that you can incorporate other parts of things in there. So if some people like exercising in a group, and if that's a way to have a bit of a support group around you as well, and some social interaction, then that might be quite important. It might be that you like being outside in nature, and that walking is a good way to do that. So it's just about, it's not important to do a specific thing. It's important to do something that you like, essentially, would be my advice there.
It is something else I suggest my patients when they say, I don't like sports. What about dancing? Why don't you go to dance? Any kind of dance would be nice. If you enjoy it, it would be moving, and that would be good anyway. Find what you like funny for you, and you can do a long term.
There's a comment in the Q&A, a comment and a question about singing as well. So anything that gets you breathing deeply is a good thing. There's evidence singing for COPD actually helps the quality of life in COPD patients. So something that sometimes comes up with my patients who've got a lot of breathlessness is they worry that exercise might be dangerous or harmful if they get very out of breath when they're doing things. Just address that one, Fiona.
Yeah, I mean, that is something that often comes up for me with patients as well. And I think that the key message is you're not gonna do yourself any harm. And actually, it's very difficult when you have a chronic lung problem where you might get breathless, because breathlessness does send alarm signals to your brain that make you feel worried about being breathless. But if you exercise regularly, and I guess as someone who does, I know that actually it's fine. I'm breathless when I exercise, but it's normal to be breathless when you're moving. And the more you do it, to an extent, the less breathless you will get. So doing what you can within your limits and starting to just push those a little bit will help. It won't do you any harm.
Okay. Does that also goes for sporting outside? For example, running, or I do rowing myself with different weather conditions.
I think you probably have to be a little bit careful and just work within your own personal limits. So if, for example, you find that cold air is a bit of a trigger for your condition, then you might have to be a bit careful around that. But generally speaking, whatever you can do, definitely do. Exercise will make you breathless, and that's just part of how it does what it does. It's not a problem.
There's a couple of questions in the Q&A about gut health and whether taking too many antibiotics causes gut problems with the microbiome, and if there's anything people can do to help with their gut. Who wants to take that one?
Maybe I can start, and Fiona can add something on. So antibiotics obviously can alter the gut microbiome, right? So, and also consider this is one of the reasons you also want to use antibiotics very carefully, properly. It is also, keep in mind, it's something that is a short-term intervention. So a bug will become resistant if you use an antibiotic over and over and over. So we need to use them when they are necessary. But this is one of the side effects. We're altering the balance between microbes in the gut. So a good solution could be to associate probiotics, particularly for those, for example, people on chronic azithromycin, find useful to alternate azithromycin with probiotics on alternate day to make the imbalance less important. The same for acute exacerbations. Amoxiclav is an antibiotic, often causes diarrhea and other colitic problems. So it could be also useful to associate probiotics in these kind of infections. But again, I think the most important thing is to use antibiotics the right way and try to reduce their use when it is not necessary, because of course they will alter your gut.
Thank you very much, Eva, and thank you to both of you for brilliant presentations, and Annetta for co-chairing this session. I suggest you look at the chat, both of you, because there's lots of lovely comments about your presentations and how much people have enjoyed the information that you've shared. We're going to a break now.
Just a final question for Fiona. Can I become one of your patients, please?
Of course. Lovely. Thank you, Eva. That's very kind of you.
So we'll see you in 10 minutes for the final session of the day. Thanks, everybody.
Thank you.
Okay, Barbara and Fiona, do you want to start?
Yes, so hello everyone and welcome back to the fourth and final session of the day on shared decision making and what works in bronchiectasis, which we all want to know about. My name is Barbara Crossley and I live in the Peak District in the UK. I've been a member of the European Lung Foundation's Patient Advisory Group since 2017, and I've had bronchiectasis since childhood. Now over to my co-host, Fiona, who you may have seen earlier on, but she'll introduce herself again.
Thanks, Barbara. I'm Fiona Musgrove. I'm a GP with a special interest in respiratory medicine and particularly in bronchiectasis. And I work in Aberdeen up in the northeast of Scotland. And it's a pleasure to be co-chairing this with you today, Barbara.
Thank you. So before we introduce our first speaker, we'd like to ask you a few questions about your experience of airway clearance techniques. A pop-up will appear on your screen inviting you to the poll, or you can click on the link in the chat or scan the QR code on screen. Claire, can you share the poll, please? So have you been taught an airway clearance technique? Oh, the vast majority appear to have been taught how to do it. Yes.
Yeah, still going, and it looks, again, overwhelmingly positive. Lots of you have been taught an airway clearance technique, which is good to hear.
And how long did it take for you to decide if the airway clearance technique you were first taught was working or not working for you? Considerable variation there.
Yeah.
I think if it takes more than 3 months, it's probably not working. What do you think, Fiona?
Potentially, yeah. I guess it takes people a little while to get used to things, though. That might explain the variation there.
Have you ever been offered more than one choice of airway clearance technique? Oh, that's fairly equal. Yeah. Well, a bit more. I've only been offered one. If you were offered more than one choice of airway clearance technique, when was this offered to you?
Again, a bit of a spread there, isn't there?
There is, yep, there does seem to be.
But not very many offered it at the first appointment.
Perhaps to avoid confusion. when do you think it would be best to offer a patient a choice of airway clearance techniques? Well, that makes sense. More people think it should be done at a follow-up appointment when they consider whether it's working for them.
Yeah, the number for at first appointment just creeping up a wee bit at the end there. So following that series of poll questions, which I think has given us some insight into where we are with airway clearance, it is a privilege to introduce our next speaker. So Paul McCallion is an advanced respiratory physiotherapist with a special interest in bronchiectasis. He leads Newcastle upon Tyne Hospital's NHS Foundation Trust Physiotherapy Bronchiectasis Service, and he's here to give us a talk about shared decision making for airway clearance therapy. Paul, over to you.
Hello, everyone hear me okay?
Yes.
Yeah.
Grand. Well, thank you very much for to ELF and Embark for inviting me to speak today. Like I said, my name is Paul McCallion. I'm a respiratory physiotherapist in Newcastle in the UK. I've worked with bronchiectasis patients for around 11 years now, and I'm currently doing a PhD into airway clearance techniques and the use of shared decision making. So I'm delighted to be able to talk to you about this today. So I've already done the poll, so I can skip that, which has been very interesting in terms of the kind of spread of answers. And it's what's really positive was the first question, which the majority of people have been taught airway clearance techniques. So a little bit of preaching to the choir today, but that's good. So what will I be talking about? I'll be talking about what airway clearance techniques are and why they're important, how respiratory physiotherapists currently prescribe them in practice, about what shared decision making it is, and then finally why this might be useful for people with bronchiectasis. So, why is airway clearance important? Well, mucus from our lungs, which is produced in our lungs, can normally get on what we call the mucus escalator. Now, these are made from special cells inside the lungs, or ciliated cells, which you've heard about today. These are cells with hair-like fibers that brush the phlegm from these kind of lower airways up to the top airway, where we can then cough and clear them from our lungs. And we normally produce anywhere between 100 to 150 milliliters of sputum a day. Now, what happens with bronchiectasis is that sometimes this escalator can get damaged or broken. And this can happen in a few ways. So either by inflammation, which we know is a big driver in terms of causing symptoms of bronchiectasis. We heard a lot about that in previous talks today. Because of this inflammation, the escalator could basically break down and just stop working and stop moving as efficiently. Additionally, if there's too much mucus, kind of more mucus on that escalator than what we would like, it slows the escalator down. It can compress the hair-like fibers, these ciliated cells, and again, slow that mucus getting clear from the airways, causing the buildup. And then finally, in some conditions, some genetic conditions, where where the hair fibers either don't move at all or move in kind of erratic ways. So again, this can therefore cause mucus to build up, leading to further inflammation and possibly infection in the airways. And that's the reason why we get some of the symptoms. So kind of what's mucus made of? So mucus is generally made of about 95% water. And I'm going to tell the patients that to kind of say, I definitely don't cough up that stuff from my lungs. So usually mucus, like I said, 95% water. And that's why it's really important in the management of bronchiectasis to keep well hydrated and drink the appropriate amount of fluids. Now, there might be some people, for whatever reason, with other health conditions that might require them to drink less fluid or more fluid. But in general, we recommend to drink anywhere between 2 to 2.5 liters of fluid a day. Again, to keep the components of that mucus in that proportion, that 95% water and the other percentage, which I'll go into. So the 3%, this other type of cell called mucin, these are kind of gel-forming proteins. So it gives the mucus that standard appearance that we would expect. And these are secreted from the cells that you can see on the slide here. We have the hair-like cells and the escalator, and the one beside it, these secretory cells. And studies have shown that there are more of these types of cells and these gel-like proteins in people with bronchiectasis in comparison to those who don't have bronchiectasis. Now, these particular cells, this mucin is a bit heavier than what obviously kind of water is. And again, if there's more of these within that mucus layer, that green layer you see in the picture, it compresses the escalator, those ciliated cells, causing again, slowing down of that escalator, mucus to build up, further inflammation, and a cough, which can sometimes lead to chest infections if not cleared appropriately. So that brings to what is airway clearance. So there's two main principles of airway clearance. There's ventilation, which is the process of air going in and out of your lungs, and expiratory airflow, which basically moves air in a way that can shift phlegm again from the lungs and support it along that mucus escalator. We have two of those things, and usually get effective mucus clearance. So ventilation, like I said, this is the process of air getting in and out of your lungs. And we want to have good ventilation because we want good ventilation to all parts of our lungs to get the oxygen in and get those waste gases out. And normally in healthy lungs, ventilation is quite equal, but in bronchiectasis and other lung conditions, this can change. So when the lungs are damaged or there's mucus blocking certain areas of the lungs, when we breathe in, the air when we breathe in tends to ignore these bits because it's a bit too much effort to try and get past those mucus blocks. So because of that, they go into other areas, and those kind of air sacs behind those mucus plugs don't get ventilated. They don't get the air in. And because of that, that mucus then gets stuck and it's unable to move. So the way I describe this to my patients is I've got two balloons here. One's inflated, one's not inflated. I've got a marble on a table, and I point these balloons at that marble and let go of the ends. Which one's going to blow the marble off the table? I would like to say most of them say, well, clearly it's the one with the air. And well, yep, and exactly that's what we're asking our lungs to do with these mucus plugs. In order to get that mucus from those small airways to those medium and larger airways, we need something. We need air to move them forcibly along that way, which leads to the other component, the expiratory airflow. So this is the force, the speed of air coming out of your lungs, sometimes called the shearing force. And it's the force that's needed to break off or to support the mucus to come off the tubes of your lungs onto that mucus escalator to be moved to the top to be swallowed or coughed out. And sometimes with bronchiectasis, the airways or the breathing tubes can be damaged, and this can cause them to become floppy due to inflammation and the nature of the disease. And because of that, during this expiratory airflow stage, sometimes the kind of smaller and medium-sized airways can close prematurely, leading to that mucus to be blocked and to not escape, and again cause symptoms of inflammation in the lung. So why is a cough not enough? I get asked this quite a lot. I get patients come in to me and say, okay, I cough up the phlegm anyway, so what's the point in doing these airway clearance techniques? I just come in and more than big cough, big globular phlegm comes up and it's fine. So first of all, the important thing to mention is that cough is important. That's the final part of any airway clearance technique. And the positive things are it helps clear secretions from the large airways. Now, when we cough, a cough requires a deep breath in or inspiration. And then what happens is your vocal cords or glottis, your upper airway, closes to allow pressure to build up inside your chest. And then they rapidly open, the upper airways rapidly open, and allows this massive gust of air to come out, sometimes up to about 50 miles an hour, to then get the mucus gone. Now, when that happens, this forceful movement of air can be so turbulent that the smaller and medium-sized airways, they can, again, like I said, shut prematurely. And if they do, again, that leads to trapped mucus in those airways. It basically is like the mucus banging on the end of a tube where it's just completely blocked up, and therefore it doesn't move and gets stuck. Now, the huff, which many of you might have heard of, is a component of several different airway clearance techniques. And I describe this to my patients as if you've got a mirror or, for example, the lens of a pair of glasses, and you want to steam it up with your breath. Now, this can be performed at different lung volumes depending on where you're trying to move the mucus. But during this maneuver, unlike the cough, your glottis or upper airways stay open, they stay patent. And why that's important is you're able to generate that air flowing away that supports the mucus from the lower airways up to the top, but it's not as forceful in order to kind of close those airways down prematurely. So it allows that phlegm to come up. Now, like any other technique, it can be done incorrectly. And some patients still do sometimes get mucus traps. So it is worth getting reviewed by a physiotherapist in order to see which one or which type of huff is the best one for you. So again, just summarizing that airway clearance, that combination of good ventilation, good expiratory airflow to get effective mucus clearance. So how do physios prescribe airway clearance techniques at the minute? Well, like anything else, like every other member of the multidisciplinary team, we do a comprehensive assessment. We want to understand the patient's understanding of their prescription and of their bronchiectasis. That's why you're all here today. If you get a patient well educated, they know why they're doing it, and they're way more likely to be kind of on board with the treatment. So that's the first and most important thing. We then look at dexterity and mobility. So again, some airway clearance techniques will involve patients to kind of move in particular ways, or depending if they have adjuncts or devices, they'll need to open them or clean them. And again, this can require fine motor skills that isn't always applicable for all patients. We then look at timing with other medications. So we know in the cystic fibrosis world, we used to nebulize a particular type of therapy before physio. But, if patients are on inhaled therapy, I know there's been some questions on that, when to take inhalers, when to take nebulizers, when to take medicines. So it's important to try and fit their airway clearance techniques alongside those. The frequency per day, how many times a day are we going to be asking patients to do this? The duration, how long are the sessions going to be? Life commitments, it's going to vary from person to person about what they have to do in their day-to-day basis. And the one highlighted in yellow here is the preference, and that's a big part of what shared decision-making is, which I'll get on to in a few slides. And then I always end on what to do if. I always want to ask my patients and get them involved on, do they foresee any barriers? Can they predict any things that might be difficult to fit airway clearance techniques into their lifestyle, and then discuss it from there. And this is just a snapshot of some of the different available airway clearance techniques. As you can see, this isn't comprehensive at all. There's quite a lot out there. Like, depending on which country you live in the healthcare system that like I said, that you live in, some of these may or may not be available, but there are quite a lot. Many of these are used in the UK, Europe, and the Americas, and worldwide. And what's becoming quite interesting now, there's emerging data on using singing and playing like woodwind or kind of brass musical instruments, and of course exercise, either in addition or even as a replacement of these traditional airway clearance techniques. And it can be sort of easy to see kind of why they're a bit more attractive. Patients might find them a bit more fun, a bit more social in comparison to the traditional airway clearance techniques. But like every technique, it is important to discuss the balance between what patients wish to do for their airway clearance and the effectiveness of that particular technique for that specific patient. So what are the challenges? Well, like I said, there's quite a lot of challenges for both the patient and the physiotherapist when it comes to prescription of what might be right. For example, exacerbations. The patients who have will have an increased treatment burden. Think about it, you're going to be taking antibiotics, potentially intravenous antibiotics or extra nebulized therapies. And airway clearance can sometimes be seen as another thing to add to the list and be prioritized out. And ironically, lots of patients actually produce more phlegm when they're unwell, so it's even more important. That then feeds on to the next one, like fatigue. If you can imagine, this will influence the quality or the length of the patient's usual airway clearance techniques or airway clearance technique sessions. Many techniques do require active participation and some level of effort. So again, that could be influenced day to day or even during an exacerbation. Importance, the one I've got at the bottom is, again, that goes back to the education. It's been well documented that patients who do not perform regular physio or regular airway clearance, they just don't see them as an essential part of the management of the bronchiectasis. So education is a key component. Time, it's well documented again that patients feel that they don't have enough time. They have a time sometimes to take an inhaler, time to take a pill, but that kind of commitment to airway clearance can just be that too much of a burden. And some studies, show that airway clearance techniques can last from anywhere between 5 to 60 minutes. So it is quite a lot of a commitment that a patient needs. So again, going back to the education onto why it's important and coming to that pragmatic choice with patients is important. Other priorities, unintentional neglect. There's busy lifestyles. You've got work, you've got school, you've got children, you have care responsibilities, and life can sometimes just get in the way. So again, I really do like to spend time to discuss my patient's lifestyle when deciding what might be best for them. And finally, I've got money there. Now, again, this is going to be based, like I said, on the individual healthcare system where you live. It could sometimes be a postcode lottery up here in the UK. About the affordability or the availability of some of these airway clearance techniques. So which ones are used most in the UK and beyond at the minute? So this is a study, like I said, from the UK, in Northern Ireland, hence the accent. And the most common one that we saw is the active cycle of breathing technique, which I'm going to go into. The second most common in red, the little bars in red at the top there, these are all types of devices called oscillating devices. And again, I'm going to speak a little bit about those as well. And it's similar when we look in Europe. This is a study done by a colleague down in London and James Shawers and a few other colleagues, which again showed that if for patients who did perform airway clearance techniques, the active cycle was the most common one taught. And then in second, these oscillating devices. Again, that's not, throughout Europe, there were different countries that ranked the active cycle a bit further down, but on average, it was the most popular technique used. So what is the active cycle of breathing technique? Well, we've got three components, two of them of the basic principles of airway clearance, as I mentioned before, about good ventilation and expiratory airflow. But the first bit, the breathing control, sometimes overlooked the patients, and it's a really, really important step. And why it's important is that as a physio, I want to understand and assess what my patients' normal breathing mechanics look like. Are they using their diaphragm, which is your main breathing muscle, effectively? So your diaphragm should do about 80% of the work when you're breathing. And only your kind of upper airways, your shoulders, and some of the muscles around your rib cage should really be working about 20% of the time. And if that ratio is significantly off, then that's going to impact what's going to happen when I get a patient to take a deep breath. If they're not using that diaphragm, that main breathing muscle effectively, that can have an impact, like I said, on how well they're going to ventilate the lungs, and therefore directly impact how well their secretion clearance or airway clearance is going to be. We then move on to deep breaths. So as you can see here, what this little drawing is the kind of end of your lungs, the little the final tubes with the air sacs that transport the oxygen into the bloodstream and from the carbon dioxide back into the lungs. And there's a little teeny tiny little mucus ball there, and your lungs are very clever. When you take a deep breath in, if there is those blockages, there's some back doors or trap doors that the air can get behind, and then during that expiratory airflow, nudge that little mucus plug toward those bigger tubes and onto that mucus escalator. Again, the final part of it is that huff, or we call forced expiratory technique, creating that expiratory flow, that shearing force to get the mucus nice and high, and again, keeping the upper airway patent to minimize the potential closure of, or airway closure of, those medium-sized airways. Oscillating devices. So again, there are a range of these available, which kind of differ throughout the countries, throughout the world. But in a nutshell, they all have, again, a similar principle. Picture one here shows an airway that's plugged with mucus. When patients breathe out into these devices, so sometimes called exhalers, so you actually blow into them, what happens is the device creates a resistance, which basically slows the patient's breath out. And what happens inside the lungs then is that there's a pressure generated to support those airways to open up, so support a bit of a gap in between the mucus plug. They then oscillate, so again, oscillating to help kind of mimic or support the movement of that mucus escalator. And sometimes the actual vibrations can help thin and break the bonds of that mucus in order to support, again, the mucus to move a bit further up to the lungs to be cleared. So shared decision making, what is it? It's a process. It's a process of communication in which a clinician or healthcare profession and a patient work together to make decisions using the best available evidence. The process is to make sure that patients understand the care, support, and the treatment options available to them. And that includes the positives and the negatives associated with each of those treatment options. The options should be given to patients in a way that's easily understood without complex medical terminology. And then the healthcare profession and the patient should discuss the options before coming to a joint decision on which is preferred. So the 7 kind of steps, which again is inviting the patient to participate, which that in itself can be a bit of a challenge for some for physiotherapists in general. Some people just do they just want to be told what to do, and others do want to kind of participate a bit more. So that's a kind of key part of shared decision making. We want to present the options, like I said, benefits and risks, discussing with the patient, and then supporting that engagement in decision. And if possible, the 7th stage here, which isn't always possible, is that the evidence shows that for shared decision making, if you involve a trusted other, such as family or close friends, to support in making the decision, you're more likely to commit to that chosen treatment. So thinking about relevance to physio, it's committing to that airway clearance. So why use it? Why should we be thinking about shared decision making for airway clearance? Well, what we know is airway clearance techniques work. We know that they improve patients' daily symptoms, they improve quality of life, and they can contribute to better disease control and reduce exacerbations or flare-ups. But what we don't know is which one's best for patients. And that's where shared decision making can be really useful. As previously discussed, there's many types of airway clearance techniques options available for patients, and sometimes what the physiotherapist is confident in teaching or prescribing may not be the best one, or may not be the one that the patient wishes to engage with. If that then leads to non-compliance or non-adherence, then we know that that's associated with worse health outcomes. So does it work? Well, yes, it does. So studies have shown that shared decision making in other conditions such as asthma, cancer, and diabetes have shown improved understanding of the healthcare condition. Again, a big component of why we're here today, to get that education component, improve quality of life, reduce healthcare usage. These things, by that I mean GP visits and hospital visits or unplanned hospital visits, improved adherence with medicines and treatment. Now, again, these outcomes are not exhaustive, and I must mention that there are other contributors to these results in some of the studies as well. So I know the slide's a bit busy, but the slides will be available hopefully on the ELF website. But this is a step-by-step chart from the bronchiectasis guidelines in the UK. And the guidelines recommend here that the first stage should be the active cycle of breathing. If that doesn't work with the patient's non-adherence, to then go to those oscillating devices, as previously mentioned. And then step 3 is that if the symptoms still don't improve, to add the use of a medication called hypertonic saline. This is kind of a salt water that can be used in a nebulized form. So it's a liquid that gets turned into a mist that the patient then inhales. And the medicine basically is there to add some fluid to that mucus escalator to allow the mucus to be slippier and easier to clear. And the salt content as well can kind of break down the thickness of the phlegm again, making it easier. Now, these options can be great to provide respiratory physios a routine and step-by-step method to provide treatment to patients. However, it can also restrict how involved patients are. That again may influence how likely they are to commit to this essential treatment. So despite what that fantastic poll showed, the majority of people here have been taught an airway clearance technique, we know that around 1 in 3, so 30% of patients with bronchiectasis, only 1 in 3 perform regular airway clearance techniques. Now, there are various reasons for this, but I feel that we as healthcare professionals and as respiratory physiotherapists should be trying to look at alternative ways to support patients to engage more with this essential therapy. And this is where shared decision-making could help. If patients were more engaged, more educated, and more empowered to choose what airway clearance technique that they feel might be right for them, for their bronchiectasis, they may be more likely to commit to it on a regular basis. And as we know, the evidence says that patients who perform regular airway clearance techniques do better. So in summary, airway clearance techniques are essential for managing bronchiectasis, and I've convinced you of that. There are many different airway clearance techniques available, and shared decision making could be useful to help you decide which one is best for you. So again, thank you very much for the invite to speak, and I will happily take any questions, and I'll stop sharing.
Thank you so much. That was really interesting for anybody who does airway clearance techniques. So now we'll go on to the Q&A session. We have quite a few questions for you.
Good.
We'll start with, something that hasn't been covered at all today, I don't think. One respondent says, I have no sputum. In other words, she has what's called dry bronchiectasis. Should they be taught airway clearance techniques? Is it still useful to know how to do them, even if you don't have a lot of sputum?
So again, I think, and again, please correct me if I'm wrong, James or anyone else in the panel, I think it's about 1 in 5 sometimes can actually have this dry bronchiectasis where they just, they've got it radiologically in the scan, but they just physically don't produce any phlegm. Sometimes it's based if I have the scale available, if there's mucus kind of deeper down in the airways where we know it's there, but they physically can't see a tangible result. I do then teach it. I kind of say, well, look, we can see that it's down there, and if it stays there for long enough, it can cause, again, that process of inflammation and lead to further chest infections. I think I can totally understand that sometimes when you just say, yeah, Paul, I've done it, for 3 months and not coughed up one thing, the next question tends to be, have you been poorly? Have you been sick? Have you been ill? And they say, no, fantastic, keep doing it. But I think at the end of the day, knowing about it and to have those tools available so that should you become symptomatic, you have them there, you know how to perform them. I think that's probably the best thing, yeah.
Thank you.
Well, there's lots of great questions, so hopefully we can get through a few of these. I've got a question in the chat about fluid intake and how important that is, and whether it has to be all sort of measured water that you drink, or whether fluid and soups and things that you're having through the day counts. I wonder if you could touch on that for us.
Yeah, I get asked a lot, especially by people who say I drink 7 cups of coffee a day. I'm like, okay. So fluid, yeah, it is important. And I think my speech and language therapist colleagues, again, I get a lot of my advice from them with regards to this, and they say fluid's fluid. Now, ideally, depending on the additional things that you're drinking, fizzy pop, that can contribute, we know, to kind of gastroesophageal reflux that can worsen symptoms. Caffeine, again, that can make you more anxious, which can give you more symptoms. So even though, yes, fluid does count no matter where it comes from, it's the additional components that can add to symptoms. So it's important that, water tends to be kind of easiest. It's the most boring to drink, but, it tends to be the easiest with less side effects compared to, like energy drinks and things like that.
Excellent. Thanks, Paul.
Now, I have a question about when to do the airway clearance around your daily nebulizing. Does it depend what you're nebulizing, whether it's saline or antibiotics? I would think, from my own experience, you would use the saline straight before you do the airway clearance technique, and maybe the antibiotic afterwards. But I bow to the professional. You tell us.
So I would normally recommend if patients producing like hypertonic or kind of even isotonic saline to use that first or sometimes at the same time. So there are some techniques where you can actually do your active cycle or other adjuncts at the same time as your nebulized kind of saline therapy. Now, yes, in an ideal world, it makes sense that if you clear the mucus from your lungs before you would take a nebulized medication such as clindamycin or gentamicin, that, the areas that phlegm was blocking up, that phlegm now removed and that nebulized medicine can therefore get in. That makes sense. However, and again, this will have to be careful with my medical colleagues. If I have had patients who say, Paul, I'm going to take my gentamicin and my clindamycin nebulizer. I'm not going to do my physio before, but I'll do it during it. I'll take anything I can get. So if that fits into their lifestyle, that time burden, we need to be pragmatic with people's lifestyles. So yeah, ideal world, we could set it up, but we have to come to compromises, and that's the important involvement patients in that decision making. What do they want to do? What can they do? And as clinicians, sometimes we might have best laid plans, but they don't always work, and that's fine.
So this might be a tricky one, so apologies in advance. But there's a question about limited access to physios, and I guess my kind of follow on from that is lots of patients will be in a situation where they don't have a physio for whatever reason. What can patients do in that situation to help learn about airway clearance, and also just thinking a bit about adjuncts? Are there, ways they can sort of look into that and reliable resources around that?
Yeah, so again, this relies on digital literacy as well. Obviously, you assume that everyone on here has got the ability to go online. There are some fantastic resources out there, again, different countries. I know there's an Australian bronchiectasis toolbox that's fantastic. There's a Canadian bronchiectasis, and gets impact bronchiectasis. We've got one, I'll plug it, from Newcastle, bronchiectasis.me, so bronchiectasis.me, which is a patient co-produced website with lots of information, airway clearance, adjuncts, and again, a really good educational kind of platforms that you can look at. So yes, it's out there. It's maybe not as promoted as much as what it kind of should be, but again, you need to be, obviously, from a website point of view, digitally literate to get there, and sometimes that in itself can be, can affect lots of other patients who unfortunately don't have access.
Thanks, that's a great answer, Paul.
I have a question. How often should airway clearance techniques be reviewed with the professional?
That's a good one. So historically, within the same as CF world, we used to kind of see them in 3 months, and then do annual reviews. I don't necessarily think that that's needed. The guidelines, our UK guidelines, say after the initial, it should be 3 months. And then after that, if a patient feels they need a top-up, I would argue it's very similar to inhalers. If I said, well, how often should you check inhaler technique? That's going to depend on the doctor, nurse, or pharmacist I speak to. But the technique with the inhaler is just as important as your technique with your airway clearance. If a patient finds it's becoming a bit rusty, and that will vary. I get some patients within 2 weeks, won't have a clue. Others, they'll be bulletproof for years. So there's no, I'll go on the fence here. There's no right or wrong specific definition, but I feel that for my patients, if they feel that they kind of want to be reviewed or think it isn't working, I tend to go on kind of patient request. Or again, if they're having a significant amount of flare-ups, it's a bit of a red flag, thinking they're on decent optimized medical therapy, yet they are still exacerbating. Let me double check to make sure that what they think they're doing correctly is correct.
So there is a question in the Q&A about what to do if mucus is just getting stuck and coughing is really painful. What are the options there? What might you suggest for patients in that scenario?
I'd want to know kind of, is it just the cough that's painful? You can imagine coughs that are associated with kind of rib pain, kind of chest wall pain, things that we do for patients with rib fractures. That I know this isn't necessarily a rib fracture question. Actually putting a towel or a pillow wrapped around just, again, minimizes how much the kind of ribs move kind of against the lung. You still get the effectiveness of the cough, but you don't get as kind of harsh movement, and that can sometimes take the edge off effective pain relief. But depending on the type of pain, I would want to kind of investigate that. Is it a dull muscular ache? Is it something sharp and stabby? I'd probably want to investigate that to rule out anything else first before jump into, I'll just put a pillow on it.
Yeah, excellent. Thanks, Paul.
I have a question. I use postural drainage in combination with my autogenic drainage. In other words, I perform the autogenic drainage breathing exercises on a slope with my head lower than my body. Earlier on, we heard advice for people with gastrointestinal reflux that they should be the other way around. They should have their head higher than their body. How do you reconcile the two bits of advice, which
can seem a bit contradictory? So I think what normally I recommend is number one, it depends on how severe your reflux is. So lots of patients get reflux just after they eat. So if that was one of the cases, I get them to do the physiotherapy before they eat, or at least leave a 4-hour gap to allow time for digestion. The other thing is that if that still wasn't working and you were doing all the things that Fiona had advised earlier in her talk and you were still getting symptoms, that again, that is that should be discussed with the physio about saying, I cannot do this. Can I have an alternative technique? And that's why there are those multiple techniques available. As soon as one becomes contraindicated or less preferred than the other, that's where the patient needs to be discussing with the physio to say, I normally do that, but I can't do that now because it's another thing. And that happens. Like, like patients will develop things throughout their life. And again, it's our job as health professionals to support them to mitigate that.
Right. Thank you. I think we've run out of time for the verbal questions, but we'll answer written questions in the Q&A. So thank you so much, Paul.
Thank you.
And we're going to hear again from you later and from Fiona. So now, having heard from the professional, we go on to what works in real life for patients. In this forthcoming video, we hear from some members of our bronchiectasis patient advisory group about how they deal with the everyday challenges of living with bronchiectasis. We're also delighted to have contributions from 2 patients from Singapore. Claire, can we have the video now, please?
How do I manage this illness? The best form of managing the illness is to clear your airways, learning how to expel your phlegm. So that was probably the most critical thing that I learned. If I can get my mucus out of my body, the phlegm out of my body, I find that I breathe so much better.
This is the position I use at the very end of my airway clearance exercises, which I do twice a day. I do it in various positions, and nowadays I use autogenic drainage, but I always end up in this position, and I'll tell you why. I may think I've completely finished with the other positions, but when I come down on my back with my knees up on a chair, my head on a cushion, and I find it helps to hold your head too, I find I can bring up a whole load more sputum than before. So it's worth a try.
If you can clear your phlegm, it's good. So I just pick up this one tip, and I make sure every afternoon when I came back from work, the first thing I do is to expel my phlegm. So I know that by lying down on my side, after a while, at about afternoon, 3-4 o'clock, naturally the phlegm will come up.
My tip is to breathe through your nose and hum. Breathing through your nose cleanses and moisturizes the air as you breathe in. It improves your lung function, increases oxygen uptake, and possibly helps fight off infections. And humming for just 15 seconds sterilizes your sinuses. I used to have a constantly runny nose, but since I've been humming and nose breathing, that's stopped.
Have a healthy lifestyle, basically. Keep yourself active, exercise, a healthy diet, drink a lot of water, hydration is important, and have a positive mindset.
I've done running and cycling, but I try and make sure that I do it off-road, so on bumpy roads, because that helps me to bring secretions up. But with that, I found that, especially in the beginning, I had to start off slowly and build up to it, because obviously, having a lung condition, you're not able to go and run 5 kilometers just straight off the bat. You have to train up for it. So in the UK, there's a scheme called Couch to 5K, and I did that, and that really helped me to be able to build up the stamina and also condition my chest into being able to run, and also subsequently be able to cycle as well.
The moment I discovered that I have bronchiectasis, I have this lung condition at that time, I knew I got to do something, and that is to keep myself healthy. I started the Qigong. It's called 3-1-2 meridian exercise. So if you look it up on the internet, you might find something about it. They say deep breathing is very good for expelling the phlegm. And I was doing that all the while because this Qigong involved abdominal breathing.
I feel that if you can try and incorporate physio into what you do, then that can really help. Because if you can get fun out of what you're doing to help your chest and you can get joy out of that, then that for me would be really good. Personally, I play the trumpet and I also run and cycle. At first, they weren't easy to do and I had to build up a lot of stamina to do it and condition my lungs. But they've been really beneficial to me both physically and mentally over the years. So I think if you can, it would be a great place to start. I always carry tissues and I always carry water around with me so that I'm able to quickly deal with my cough if I ever get one. I also have a Ventolin inhaler likewise, so that if I do cough, I can hopefully go and excuse myself from a room and then come back in a couple of minutes later when my cough's gone away.
I remember when I was working that time, and when you have to attend important meeting or make an important presentation, then my concern is usually I don't want to be caught in a situation where I'll be coughing. So what I will do is before this meeting presentation, I will drink a glass of hot water. I think that helps. And sometimes I'll take the coughing drop.
At the end of the day, if I'm going to cough, I don't want people to just think that I've got coronavirus or COVID or anything. So I'm normally quite open with people to say that I've got a lung condition, but I know other people don't feel as comfortable doing that. As long as there is a few people at least, or like maybe even one or two people that know what's wrong with you. So if you do have to excuse yourself for coughing, it's more understandable. So they understand that why you're going out and just check up on you when you get back.
When it comes to meeting new people, either it's a friendship or a romantic relationship, I used to be very scared of talking about bronchiectasis and the judgment behind it, but now it's just one of those things that I like to talk from the get-go and give people a fair chance to decide by themselves if they're comfortable or not with it, which is fine either way.
Oh, a lot of people are ignorant of this condition. They do not know. I have to explain to them. I said, it's not infectious. I said, I'm more afraid of you infecting me than I'm infecting you.
When it comes to work, I believe that talking about bronchiectasis might get a little bit more trickier. I personally don't really like to talk about health issues in the beginning. I like people to get to know me for me and for my excitement. But eventually I do talk about it because I do believe that honesty is the best policy. Even though it might not work out, I don't believe in hiding anymore, and I believe in taking any moment, even a work moment, to educate people on health issues.
You can still enjoy your company, your friends. You can still go out. It doesn't really restrict you. It's up to you, really.
Some tools I've learned in managing my anxiety, which I suffer from quite a lot, is just really learning how to set boundaries. So having some me and alone time when I need it, and especially not comparing to what other people are doing. So just really giving myself a little bit more credit about what I'm able to do while suffering from bronchiectasis.
First thing is to basically accept it. It's not the end of the world. Second thing is prepare yourself as best as you can to live with the illness.
So when it comes to coping with things not working out, which sadly happens quite a lot for us, and moving forward and accepting change, I believe that something that helped me was just having multiple plans. So I have a plan A, plan B, plan C, and if that doesn't work out, I have a plan D, and I have plenty of lists, because I do believe in having something to look forward in the future, and mostly I believe in managing expectations. So not being overly positive, not overly negative, just really finding the balance between what we want and what we can expect while living with bronchiectasis.
I always try and focus on doing the things that I can rather than I can't, and looking at, okay, I might not be able to do this one thing, but look at all these other things that I can do and try and focus on that.
So for me, getting the best out of life while having bronchiectasis just really means this constant fight for a balance between accepting that I have a health issue and embracing it while still having fun and trying to lead a normal life, and also embracing my mental health as much as I care about my physical health, because I really believe that is such an important topic for people with chronic disease.
Well, I think we're all human. There will be times when, this is the drag. But at the end of the day, say, hey, if I want to have my fellowship of my loved one, you want to go out to see the world, then you gotta do it. There's no pain, no gain, they say. You don't go through it, then you don't get to get the enjoyment that you want.
Well, thank you so much, everybody. There's some great advice on there. I think you'll agree. So now we move on to a live discussion with patients and professionals on the same topic. What we found works for us. Just remember that these are personal stories. What works for some people might not work for everyone. Bronchiectasis is an immensely variable condition and we're all different. So the best doctors and physiotherapists personalize treatment according to a patient's individual needs. They listen, explain, and involve patients in decision-making. So we have 3 of the best professionals on our discussion panel, along with 3 patients who'll tell us the therapies that work for them. So now, can I ask you to introduce yourselves? First, the patients, and Rachel, you go first.
Hi, I'm Rachel. I live between the UK and Portugal, so I've experienced both healthcare systems. We can talk about that in a minute. I think I've had bronchiectasis for about 10 years, but I was only diagnosed about 2 years ago during COVID, so it's really recent. That's me.
Thanks, Rachel. And now Ed, who we've already seen on the video.
Hi, I'm Ed. I'm 16. I was diagnosed with bronchiectasis at 8, but I started showing symptoms at 5 months old. I live in the UK, in the southeast near London, and yeah.
Thanks, Ed. And now Donna.
Hello, my name is Donna, and I currently live in Switzerland, although most of my life with bronchiectasis was in the United States. And I've been sick since I was very small, maybe 4 or 6 years old. So I have about 60 years of experience with this.
Thanks, Donna. And now the professionals. Fiona is joining us as a panelist now. Would you like to introduce yourself again, Fiona?
Yeah, I will do. Thanks, Barbara. I'm Fiona Musgrove. I'm a GP with a special interest in respiratory medicine, and I work in Aberdeen in the northeast of Scotland.
Thank you. And Michal?
Yes, thank you, Barbara. I'm Michal Steinberg. I'm a pulmonologist working in bronchiectasis and adult CF from Haifa, Israel.
And finally, Paul, if you could just introduce yourself again. Thank you.
Hi, I'm Paul. I'm a respiratory physiotherapist specializing in bronchiectasis, and I live in Newcastle in the UK.
Thanks very much. Now, if I could start the discussion with you, Rachel. As a fairly recently diagnosed patient with mild bronchiectasis, what have you found works best for you?
Yeah, so there's been a lot of really good information about airway clearance already in this conference, and all that I want to say really is that airway clearance is the only thing I need to do, and it's basically, for me, it's the difference between bronchiectasis affecting my daily life in a quite noticeable way and it not affecting it at all, apart from having to do airway clearance once a day. So as long as I do my airway clearance, I never have a cough during the day, I'm never short of breath, I can always sleep at night. I just don't notice it. If I don't do the airway clearance, if I even miss one day, some of those symptoms will come back. So the other thing I wanted to say is that I couldn't access respiratory physio in either country at the time I was diagnosed, or before or since. And obviously, ideally you would, but I just wanted to say that if you can't, or if you're waiting to access respiratory physio, there's so much information online, and you can just explore on your own, and you can just devise your own technique, which is what I've done, and it seems to work for me, and I adjust it all the time. But I did just basically try out different things that I found online to see what worked, and came to my own version.
Do you know what kind of technique you use mainly?
So I think I do a variation on the active cycle of breathing. There's some things that are really important for me. The first thing is that it really helps a lot if I do vigorous exercise beforehand. Obviously, I can't always, but if I do, then it works better. There was some discussion in the chat about laughing, and laughing and talking also do help. So I noticed that if I've been talking for a long time before, if I've been doing something like teaching or presenting or talking on the phone for a long time, then it will also work better to do airway clearance afterwards. But I do think it's really important to say that none of those things will get the mucus up from deep in the lungs on their own. You have to use them beforehand, and then you have to do your airway clearance properly to get deep down. But those things really help. The other thing that helps for me is to do it at the right time. So my lungs basically tell me when they want to do it. So I can feel the mucus wanting to come. It is usually about an hour, hour and a half after eating, but it can depend. And if I can do the airway clearance at the time when my lungs are telling me, then it will work much better. So this is ideal scenario. So there's some days when I won't be able to do it at the right time. It'll still be okay. But if I can time it from when my body's telling me it wants to do it, then it will be much better. And the other thing I've discovered is that if you do it upside down, it really helps a lot. So I do the first part of my airway clearance in a shoulder stand, which is a yoga pose. It just means that my lungs are above the level of my body. You don't have to go into a full shoulder stand. You could do something like hang off a bed. You can just do something that makes you upside down for at least part of it. And I find that really, really helps. And what I actually do is very short. So it only takes about 8 minutes. If I'm ill, I might have to do this twice a day, but normally it's just once a day for about 8 minutes. And I'll just do 3 cycles of gradually increasing the depth of the breath. So I'll do 1 cycle of 6 normal breaths and 6 huff breaths with a closed mouth. Then medium length, same thing. Then deep breaths, the same thing. And then I'll do a couple of long, slow huffs with an open mouth, and a couple of deep, fast huffs. I'll do a couple of shallow, long huffs with a closed mouth, and then a couple of deep, fast, short huffs with an open mouth, and then the phlegm will just come up for me. So that's basically what I do. It's really, really simple.
Well, thanks, Rachel. It's good to know that you're able to find your own advice and your own tuition videos, presumably.
Yeah.
By yourself online. Because for those people who can't access respiratory physiotherapists, that's good to know. Okay, we'll go on to Ed. Ed, you're younger than most of us here today. What have you found helps you cope best with bronchiectasis at school and in daily life?
So I was lucky when I was really young. I had a respiratory physio who was able to adapt her techniques around me as I got older. So when I was a toddler, she encouraged my parents to sit me on a gym ball and to bounce on that, and also on a trampoline to help move the secretions in my chest. As I've grown older, I've moved away from that, and I've turned towards sports and music to try and control my symptoms. So I initially used the a cappella when I was younger, but now I've started using the OPEP, which I think was on Paul's slide earlier, and which was basically using another oscillating device to help try and bring up secretions. But for me, when I did airway clearance, it was always when I needed it rather than on a daily basis, because I've been lucky that I haven't had to bring up secretions as often. Now I play the trumpet about 8 hours a week, so that for me I think works really well as physio. And I now rarely use the OPEP and rarely bring secretions up. But one thing I would say is if you're going to use the acapella and the OPET, and if you want to use trumpet and musical instruments, then I would say that sterilization and cleaning is really important because of the build-up of bugs that can happen inside those things. So I'm lucky that my dad offers to do it, but it can be. I have to clean my trumpet every 6 weeks and the OPET whenever I use it because I only really use the OPET now whenever I get ill. So, my physio has also taught me good tissue hygiene as well because I think that's quite important. So, bringing up secretions discreetly so that I don't draw attention to myself, and then also just not using like cotton handkerchiefs or spitting into bowls or sinks because, that for me I've found as like can sometimes harbour infections, and it also might seem obvious, but I always, when I leave the house, have water and tissues with me, just so that if I do need to bring anything up, then I've got a way of doing that safely. And also, I've got water to hydrate myself the other day. You're muted, Barbara.
Right. Amateur mistake. You mentioned in the video that you run a lot as well for you did the Couch to 5K. How's that going? Are you running further and further now?
So a couple of months ago I was doing a 5K. I was like to see how far I can go, and now I think the farthest I've gone is around 15 kilometers in one go. So I'm able to go far now.
And do you find at school that your fellow students and teachers are conscious of your condition, or do they just accept it?
I think people always know that I've got it because obviously if I'm ill then I've been coughing, but it's accepted. They know that if I have to just leave for a moment to clear my chest, and that's fine and it's accepted. And if I'm ever in a situation where I do have to leave and cough, then I just try and excuse myself, and hopefully people will understand me.
Well, that's good advice for people at work as well, I think.
Yeah.
As long as people are aware that you have a lung condition. People are more used to other people having asthma than bronchiectasis, let's face it. So I think people generally in society are aware that we might have to deal with it sometimes in difficult situations. Right, so thank you so much, Ed. We'll go on to Donna, who, like me, has been dealing with bronchiectasis for decades. So what are the different therapies you've tried, Donna, and what works best at different stages of severity?
Okay, so over the decades, I have used many different types of treatments. When I have a bad exacerbation, that includes antibiotics, and I have used oral, inhaled, and IV antibiotics. I wanted to say that I find very important to have the sputum analyzed before starting a course of antibiotics of any delivery method, in order to make sure that the antibiotic selected is actually going to work against the bacteria that are currently present. I have found that using intravenous medication, when the medication is put directly into the veins, can be highly successful, especially when I've been my most sick. However, it's no fun being in hospital, and sometimes it can be a 2-week stay. What I have been trained to do is to self-administer intravenous medications. I do this maybe once a year on average, and it's much nicer to be at home and take care of it yourself when that's possible. Of course, oral antibiotics, tablets, are much easier to fit into a regular daily life, but sometimes they don't seem to work as well as the intravenous care, for me in particular. But given that, my favorite method for taking antibiotics is inhalation, where you start with a liquid that you measure out to the proper amounts and breathe it in through a nebulizer. And I find that it's possible the medication is getting in higher amounts to where it's actually needed. I know that in some countries, inhaled antibiotics are not in favor, but I find they work very well for me. As has already been mentioned, the prevention of bacteria buildup is the most important part to not having exacerbations and staying as healthy as possible. However, when I was younger, there was no discussion at all about airway clearance techniques. It was not something that was taught, and YouTube didn't exist. So I was told to just do vigorous exercise, which I have done all of my life. As Ed, I run and find that helps to help me get the phlegm out much more readily. And I really suggest, if you're able to exercise, to give that a try. Then my current daily routine, I think, has me in the best health that I've been in for most of my life. It's taken a very long time to figure out exactly what works for my body. And of course, what works for me is my own routine. As we've heard before, everybody has their own methods and things that work for their own bodies. And it does change over time. So I wanted to urge everyone to just keep trying to find out what helps you to clear out your mucus and to feel healthy. And it has to fit in with lifestyle, as has been mentioned before. What I do now is first several steps to get ready for clearance to actually be effective. What I do is take a long-acting bronchodilator at first. And while that is starting to work, it takes about 20 minutes to become fully effective. I do a sinus rinse. I personally have very thick, sticky mucus, both in the sinuses and the lungs. And I find if I do a daily sinus rinse, then I breathe much more clearly and easily throughout the day. The next thing I do is I do a hypertonic saline nebulization, like we've already talked about. And that thins out my mucus quite a lot, makes it much easier to cough out. When I first started using this, I was at a 3% dosage and found it did absolutely nothing for me. And I moved up to a 6% concentration. But at the beginning, it was too hard and too irritating to inhale. It took a long time to work up to 6%. Now that works very, very well for me. But I do know that some people cannot take hypertonic saline. It makes them bleed, or it's just too uncomfortable. So figure out what works for you. I also have mentioned that I use a nebulizer for that hypertonic saline, and also for antibiotics on occasion. And I'm fortunate to have one that has a vibrating membrane rather than the standard machine. And what that does is it diminishes the time of treatment down from 20 minutes to about 5 minutes. And I love having that extra 15 minutes. So if that's something that would be appealing to you, maybe look into a vibrating membrane nebulizer. Then I'm finally ready for airway clearance. And I've used many types of devices, aerobicas, flutter valves, acapella. And throughout my decades, I never found any of them did anything for me. What works best is my own variation of the active cycle of breathing. And I need to do that for about 20 or 30 minutes. One thing that I didn't hear mentioned, and I do want to stress, is when I take in my inhale, I hold my breath for about 3 to 5 seconds in order to help the air in the lower airways, in the alveoli, get behind the mucus plugs, and that makes it much easier to cough out. Excuse me while I do that. Then I already mentioned vigorous physical exercise. As has been said before, it really helps me immensely, and I recommend doing that. And in conclusion, I'd like to say, excuse me, that I've had times living with this disease that were extremely depressing and anxiety-provoking. There were times when I was not able to walk up even 5 stairs without having to stop and be desperate for some breath. But now, with all these changes and putting in more techniques into my daily care, I'm living a full and active life, and I'm a happy and energetic person. And I still cough a lot, but life is really good. And I wanted to stress finally that by taking care of yourself, you can have a healthy, good quality of life. And I wish everyone the best in finding their own way.
I wholeheartedly agree, Donna. Yes, I mean it does take quite a lot of work, as you've specified. But yeah, you can have a full, healthy, well, comparatively healthy, unhappy life with bronchiectasis, as long as you can cope with all the paraphernalia that goes with it. So we'll go on to the professionals now. Fiona, as a general practitioner, could you explain the best kind of care at GP level? I know a lot of patients do not encounter the best kind of care at general practitioner level. So what would you do with a patient who you suspect might have bronchiectasis? And after diagnosis, what continuing care would you put in place?
Thanks, Barbara. It's a tricky question to answer, but I'll try my best. I think most GPs won't know an awful lot about bronchiectasis, and that is the challenge of being a GP. So we have to know a little bit about lots of things. Our key skill set is in diagnosing things and managing them at a kind of a reasonable level. And I think the most important part of that in bronchiectasis is recognizing when something might be bronchiectasis. So we're expected to be able to sort of do some straightforward investigations, so things like blood tests, chest x-rays, maybe some breathing tests. And we're also expected to be able to recognize when something doesn't sound like a condition. So for example, this patient with COPD doesn't sound like they have COPD. That might be because they've never smoked, or their spirometry doesn't fit. So that's the first thing, is actually as GPs recognizing that this might be bronchiectasis. The next bit is arranging the relevant tests, which is a high resolution CT scan, and that will depend a little bit on where you are, which part of the world you're in, whether your GP can access that test directly or whether you need referred into secondary care doctors and respiratory specialists to have that test done. So for GPs as a whole, my expectation would be to recognize that something might be bronchiectasis and to begin investigating that. That's slightly different from what I would do. So I think the challenge is significant for GPs out there, because bronchiectasis is something they might not know as much about. I've got more of an interest, so I'm likely to diagnose more of it because I see it in lots of patients and I'm thinking about it a lot. So the level of care that I would tend to provide is pretty much as I've just described. So I would think, actually, this might be bronchiectasis, and I am very fortunate that I can refer directly for high-resolution CT scan, and then I would deal with the results when I get them. And then actually, it would be about accessing those basic components of care. So that might include recommending smoking cessation if that's relevant. It might include referring to a local physio service, or accessing facilitating patients accessing resources. And it would be key things around self-management. So it would be about what to do when you get an exacerbation, how you might know that you have an exacerbation, length of treatment of an exacerbation, and that very important thing that's already been touched on of, sputum samples, when we would want to send sputum samples. So that's generally what I would do. And I do tend to keep a fairly close eye on my bronchiectasis patients, just to make sure that they're all kind of getting good care.
As we on the patient advisory group, we tend to be quite expert in our own condition, and we know where to go on the internet to get, for instance, recommended treatment guidelines. Would you recommend we as patients take that in to our general practitioner?
I don't think it's a problem to do that. I think what you have to recognize as a generalist that as science moves things forward in lots of disease areas, you aren't going to be able to keep pace with that. And information is so much more available nowadays than it has been in the past. And so I think we need to expect patients to come to us with information and to use that as part of shared decision making. I think lots of GPs think that they have to know everything or feel a bit bad when they don't know things, but the reality is that is going to happen, and it's just about how you can work together with your patient around that. So just because you don't know about bronchiectasis when someone comes in and hands you the BTS guidelines or whatever it might be, doesn't mean that you can't go away and have a brief read around and look up the key things that you need to know, which are, what do I need to do to deliver good care in primary care, and when do I need to refer, essentially? When do I need to phone a friend and ask for help here? So I think I would encourage patients to do that. I've had patients bring in things to me about various conditions that they have, and I think it's helpful, actually. Ultimately, it's all about the patient at the end of the day. And if the patient, you are an expert in your own condition, and I think we should use that.
Thanks, Fiona. That's good to know. So now we'll move on to the secondary level of the professional medical treatment, which is the clinicians. Mikhail, why do you think it's important to adapt treatment to a patient's individual challenges, and how do you involve patients in decision making?
Well, we know that bronchiectasis is a very heterogeneous disorder. We've heard about it all day, about precision medicine, and there's so much going on with individual patients. So the variability is great, and it's very important to tailor the treatment not only to the patient's condition, for example, to the severity of the patient, or whether they have a certain infection, but also to their lifestyle and their preferences. So, for example, a young person with bronchiectasis that has to go to school or university or work and very busy is very different from an elderly patient who may have other health problems. And so it's very important to take all these factors into account. And I often, when there's a few possibilities to the next step in treatment, I often share these possibilities with the patient and really make it a shared decision. And I think a great example, besides physiotherapy, which I won't touch as Paul here is the expert, one other great example is choosing between antibiotics, long-term antibiotics. We sometimes have a choice between oral, which means usually macrolides. There's been a lot of questions about it today. Whether to take macrolides or whether to take inhaled antibiotics. So they each have their pros and cons. Inhaled antibiotics takes a lot of time, and macrolides are easier to take, but have for example, GI problems. So I present the pros and cons to the patients and let them decide which first step we need to take. It's very, very important because medications don't work if people don't take them. And it's important that the patient is an active part and chooses their own treatments together with the expert.
Thank you. And what do you think of the prospects for a more holistic approach to patient care at hospital level? By which I mean involving the other different conditions and other different specialisms in your treatment of the particular patient. It's often difficult for patients to keep going to the hospital for different appointments in different departments. Is there any prospect of amalgamating them so that we can be treated as one person in one department with different specialists there?
Yes, of course, the health systems in various countries have their limitations, and doing clinics with the various specialties is sometimes not feasible, but it's really important to have a good connection with your colleagues. So, for example, if I'm treating someone with rheumatoid arthritis, I often discuss them with the rheumatologist. Someone with sinusitis and upper airways problem, I usually refer them to my favorite rhinologist and then discuss together the condition of the patient and how we can treat them holistically, as you point out, because in most patients there's more than one problem, and we need to realize that and to tailor all the treatments that the patients need to take, which can be quite burdensome. So if we can collaborate to work together and make treatments more effective and also more simple for the patients, then that would be very successful. So it's not an option in all healthcare systems, but in some it is, and it's important for, I'm sure Fiona did as well, has her favorite rheumatologist, her favorite pulmonologist, her favorite ENT specialist. It's important to build connections and collaborations and for the patients.
Thanks so much, Mikhail. That's good to hear. And now back to Paul, the physiotherapist. You mentioned that some people are doing physical exercise for airway clearance instead of traditional airway clearance techniques. Is exercise better, or should we be doing both?
Great question, and one that I'm asked quite a lot. I mean, you've heard from, Donna, Ed, and Rachel that, all of them are doing physical activity, and I think that is it's a great thing for both airway clearance and overall physical health. I think when you think about what exercise does, it is doing that first component of airway clearance. It's ventilating, it's getting the air kind of moving, getting the air behind those kind of mucus plugs. And what I normally say to patients if they are exercising, like for example, if Ed came up to me and was like, I'm already running 15 kilometers, I'm splashing it, what should I do? A little huff or a decent huff at the end of it. Again, that's just adding a very simple, very quick second component of effective airway clearance techniques. So yeah, like I said, it makes it more interesting, it makes it more enjoyable. Playing wood instruments, going to yoga, doing dance classes. If you can do those things and do physical health and airway clearance, magic, do it.
I personally find that strengthening my core, my diaphragm, stomach and back helps me do the airway clearance later on because I've stronger muscles to squeeze the lungs. Does that make sense?
It does. I mean, I think you know, when we think about that expiration component, you do need expiratory muscle groups in order to do that. Lots of kind of core exercises will strengthen those. It's an important aspect to cough as well. So in order to physically get the mucus out, you do need a strong enough cough. And you know, you can have the best airway clearance in the world, but if your cough becomes weak, which sometimes can happen, not standalone with bronchiectasis, but also with additional conditions, then yeah, things like exercise and core exercises can support that. But yeah, like I said, all exercise is good. If you're moving, you're doing well.
Great. Okay, well, I think we've come to the end of our time here. So I'd just like to thank everyone who took part. I really think we've covered a lot of ground here today in terms of living better with bronchiectasis in all its multiple forms. And we've included what we can do for ourselves and what the medics and researchers are doing to give us hope for a better future.
Yeah, a huge thank you to everyone that's taken part today, for all of the panelists for excellent talks, and thanks to everyone for attending this 4th annual patient conference, and keep a lookout for more events happening on the 1st of July, which is World Bronchiectasis Day. I'm just going to hand over to our co-hosts, to Michal and Eliza, to deliver our final take-homes.
So it's been a great conference. I'm not sure what to comment on first. I mean, there's so much new information for me. And even though I have learned a lot over these years, there's still new information and very nice tips that I will definitely try. I will see the recordings again, I guess. I mean, it's been, this was so informative. I want to thank myself, all the experts, for being so engaging. Not only with their patients, but also with us, with everyone having bronchiectasis. This is so much coming from them. But also I want to thank everyone that has shared their experience, either with a talk or a video or in the chats. This makes us stronger. Hearing from others.
Yeah, so it's been really inspiring for me as well. I'm sure to look up the laughter yoga advice, because I haven't heard that before. And I wish to also thank all of the patients coming in and contributing their experience, because this is a disease that we really learn from patients' experience as well, as much as we do from science. So I want to thank all the speakers, the patient contributors, the session chairs, my colleagues in EMBARC steering committee, our bronchiectasis patient advisory board, volunteers, and especially these people here that are the conference planning committee, and Rose Matson, who I'm really looking forward to seeing her drawings of today, and everyone who attended and helped promote the event. So it's been a great experience, and recordings will be available online until forever, really. And also, please look at last year's conferences. They're also available online. And I think that's it. Thank you all very much. And thank you, Eliza.
Yeah, thank you, Michal. Stay in touch. This is the website. This is our email. And have a good rest of the day. And we hope to see you again very soon.
Bye.
Goodbye. I think we have a final poll. Sorry. Yeah. So everyone that's still online, please give us some feedback. Using just one word, but then we will communicate with email, and we will love to hear more, using more words. Just be honest. Okay. Great. Okay. That's very nice. That's great. Really, thank you all. Thank you. Thank you for being here today. Thank you so much. And thanks for all the organizers. We're so grateful. Okay, so bye-bye.
Bye, everyone. Bye.
Bye.